So how much is the output like? So every day patient has to do 3 to 4 exchanges in a day. So that has to be recorded. Depending on the output, patient can have a intake. So whatever output comes in a day, out of that 3/4 has to be taken as a intake here. In hemodialysis, you will check the weight after and before and after dialysis. Here it is not like that. The patient weight will be constant because we do everyday dialysis. We should not increase or decrease. It should be a constant. Okay. If depending on the output, he has to take an intake. 3/4 should be taken as an intake. This is CAPD. Okay. So there is one more procedure called APD, automated peritoneal dialysis. So this is the advanced technology in peritoneal dialysis. Here we can do, a patient will be going to do dialysis in the night time. He need not to do anything at the day. So while going to the sleep, we have a machine called peritoneal dialysis cycler, APD cycler, which has to be connected to the patient. According to the doctor prescription, we'll program the machine and give to the patient. So what patient has to do? He has to connect and go to sleep. So what we do manually, fill, drain, that will be done by a machine for 10 to 12 hours in the night. So morning it shows end of therapy, then patient can disconnect and he will be free for the day. So again, every night he going to connect the machine and continue his dialysis. It give a daytime free for him so that he can do his normal activities in the day. So here we can do high dose PD also. High dose PD means if patient is fluid overloaded, we can use 20 liters also. Usually we use 10 liters in APD, automated peritoneal dialysis, we use 10 liters. So if patient is overloaded, we can use 20 liters also. So maximum we can connect 80 liters at a time, and machine can be run for 48 hours when patient needs it, like a fluid overload, when he is in ICU. So we can do the continuous dialysis here. NIPD, it is like a nocturnal intermediate peritoneal dialysis, which will be done in the night time, like between 9 to 12 hours, and flexible free times. So there will be a flexible free time and less connection, and due to this, there's a chance of peritoneal very less, because handling is very less here. We need to, like in the manual now, we have to do 3 to 4 time exchanges, 3 to 4 time connection, disconnection. There is a chances of more contamination. Whereas in APD, the contamination chances are very less, because one connection and one disconnection in the day. So if in case of low transporters, I told you, low transport need a continuous dialysis. In case of low transporters, we can give a day dwell also. So in a machine, there is a option called day dwell. When we give that day dwell, what happens? Out of 10 liters, fill volume will be 2 liters per exchanges. So 4 exchange happens in the night. And there is a 2 liters get filled in the morning and it stops automatically. So that will be there for the day, because in a low transporter, we can keep it for 8 to 10 hours. So daytime, patient will have that fluid inside. In the evening, again, after his dinner, again he can connect, and there will be a 4 exchange happening here. So patient need not to do anything in the daytime. And in nocturnal peritoneal dialysis, advantages: lifestyle, flexibility, and efficiency and safety. And patient also feel good that daytime we need not to do anything. If there is a patient who is working and he is the breadwinner for the family, so he can go for a APD so that he can do his dialysis at the night and he can work in the daytime. So it won't affect his family life. And this is the cycler we are using for the peritoneal dialysis. And the dimension of the machine is around 7 inches height, 18.6 inches width, and 15.7 inches depth. And weight is around 12.3 kg, and power consumption is 600 watts, and battery backup is 2 hours. This battery backup is there for only for memory. During that time when power goes off, the battery backup will be for 2 hours for the memory. it will, once power comes out, it will start from where it stops, but it won't work. So definitely, patient should have a UPS backup here for APD, automated peritoneal dialysis. Okay. So here there are different therapies: CCPD, continuous cyclic peritoneal dialysis; IPD, intermittent peritoneal dialysis, and there is a tidal therapy. I'll show you when I'm doing the demo there. Then there is a high dose CCPD. High dose CCPD means we can connect like 20 to 48 liters together at a time, and high dose tidal. High dose tidal also we can do. Parameters, we have to, parameters which should be adjusted is from volume. Fill volume can like a 200 ml to 80,000 ml. We can be programmed at a time. We can connect like 80 liters of fluid at a time, from 200 ml to 80 liters. And therapy time like 10 minutes to 48 hours, we can do the dialysis. Fill volume will be from 100 ml to 3000 ml. Then last fill volume will be 0 to 3000 ml. Then a dextrose, same dextrose or different dextrose. And we are, apart from dextrose fluid, we have another fluid called icodextrin. That's why they are given here same dextrose or different dextrose. So when we connect other dextrose to the machine, then you have to change that program to different dextrose. If both the bags are same, like dextrose bag, then it should be same. Otherwise, it's a different dextrose. I'll show it in the demo. So these are the things we needed. One is 5 liters bag. These are 5 liters bags. We need 2 bags in a day. And this is called prawn set, 4 prawn set or cassette. These are tubings we need. Then we need a mini cap to close the patient catheter. So here no, nothing will be reused here. Everything will be use and throw. So everything will come in a sterile packing. Use it, and every day you have to take a new sets of PD, cassette, and mini cap. And we have a tubings for pediatric patients also. Is a low cycle cassette that has to be taken for pediatric. And there is in machine there is a standard mode and low fill mode. Low fill mode for the pediatric patient and standard mode for the adult patients. Okay. So now we can see APD video, how a patient will do at home. So that I can't show completely here, so that we have a video. So we're going to play a video. Just see the video, and so that you can understand better when I do the APD demo there. Inserted by a urologist or a surgeon into the peritoneal cavity, it will place in the pelvis. So the inner tip will be in the pelvis, and the outer tip will be exited out of the abdomen. So once catheter is inserted, then we'll give a break of 2 weeks, so that the exit site should heal properly. So once exit site heals properly, then only we start peritoneal dialysis. In between 14 days, we do flushing to keep a catheter patent. So we do a flushing like 3 to 4 times, like once in 4 to 5 days, so that we fill the fluid inside and will drain out. We'll give a wash like once in 5 days. So catheter has to be patent till that 14 days. After 14 days, we start ITP, initial training protocol for the patient. It will be 5 days. 5 days training will be given to the patient, and he'll be trained on everything. There will be a exchange procedure, IP medication, how to give intraperitoneal medication, then how to do exit site dressing. Every day they have to do exit site dressing. So that has to be trained to them, and how to sterilize at home. We give them how to sterilize at home. So all the training will be given in 5 days. After 5 days, patient will be doing the peritoneal dialysis at home. And once they start doing, and we have a coordinator, they will be visiting their house every 15 days, so that how patient is following the procedure. Is there following the stepwise procedure? There is any break-in in their steps, they are wearing a mask or following the aseptic technique, we'll see that and we'll retrain them again for 3 months continuously. Like monthly, twice we visit them and retrain them there. So after 3 months, then again there will be visits of every month. Every month we'll go and visit the patient. So like that now, continuous follow-up will be there. Here, that continuous follow-up will be required. Otherwise, patient won't do properly. They start bypassing the procedure and they do as they like. So they'll, in PD, most important thing is follow-up. Follow-up should be there and patient has to come back to the doctor once in a month. And with the blood investigation, then doctor according to that change the prescription and depending on that, patient will be continuing the procedure. Like the PD will be, we follow up like that. So now in India, all the support will be given by the Baxter people. Baxter have a clinical team which will do all the things. Only few hospitals are taken ownership, like Manipal in Bangalore, NU Hospital in Bangalore. They got their technician trained by us in a PD and they will be doing all the things. Only home visit will be done by us in only few hospitals. Apart from those hospitals, other hospitals will take care of patients. After catheter insertion, patient will be given to us and we'll train them, we'll do the follow-ups, we'll give the feedback to the doctors. So patient will be visiting the doctor once in a month. And as you know very well, there is no much complication in PD as compared to HD. And you have seen now in HD there will be a lot of complications like up and downs. So because it will be done once in 2 to 3 days. So there will be collections, immediately they remove, there will be a fluctuation in blood pressure, patient will feel tired, there will be cramps. So all those problems not there in PD. Okay, PD, there is only one problem, only one complication is peritonitis. If you follow the aseptic technique properly, it can be avoided. So we have a lot of patients who are doing from last 10 years, 20 years also. So there is a patient who is doing from 20 years and when we started, the patient was around 7 years. Now she has completed her MSc and done PhD and working in a Rani Chennamma University as a lecturer. Still she is doing on PD with manual PD. So PD is very good for the patient if you start early. One of the most advantage in PD is it preserves residual renal function. So if it preserves residual renal function, quality of the life of the patient will be good initially, like 4 to 5 years. So that if you start PD, so patient axis can be, hemodialysis axis can be preserved. So that hemodialysis can be started anytime. So we can prolong the patient life. So there are countries who have done that PD first policy. So they start with PD, then continue with the HD after some years. So, but in India it is reverse case. Like first they put on HD, when all the axis fails, then they put them on PD. That won't give a good survival benefit in PD. So if PD start early, the quality of life will be good for the patient, then we can prolong the patient life. Video nodana idu. So video, when you see the video, so you can understand properly here, because I can't do complete cycle here because of there is no patient, it's not connected to the patient. So we can see the video so that you can understand better.
You can make time for work, for family and friends. Feel confident. Be independent. Lessen your anxiety by adding wings to desire. With the Home Choice Pro automated peritoneal dialysis system. The Home Choice Pro automated peritoneal dialysis system can be set up in short, simple steps. First, wash your hands. The right way to wash your hands is to begin by rubbing the palms vigorously together with soap. Next, continue rubbing palm to palm with the fingers interlaced. Rub the right palm over the left dorsum. Then, change hands and rub the left palm over the right dorsum. Next, interlace your fingers with the left palm over the right dorsum. Change hands and repeat. The next step is to rub the backs of the fingers of one hand of the opposing palm with the fingers interlocked. After that, rub the left thumb in a rotational forwards and backwards motion with the right hand. Change hands and repeat. Next, rub the left palm backwards and forwards with the clasped fingers of the right hand. Change hands and repeat. The last step involves rubbing the fingertips of the right hand into the left palm. Change hands and repeat the action. The next step is to gather all the required supplies as shown here: solution bags, drain bag, disposable set, mini cap, face mask, and alcohol hand rub. Now let's begin by switching the machine on. When the system is ready, the following message is displayed. Press Go to Start. When you see this message, place the solution bag on the heater. It is now time to load the set as shown here. Next, press the green button. Now open the door and fix the cassette. Once you have fixed the cassette properly, close the door. Now place the line set or organizer on the door. Close all the 6 clamps. Next, press the green button. After around 2 minutes, the display will show the following message: Self-testing. The display now changes to Connect bag. It is now time to start connecting the bags. Begin by removing line number 1 and connect it with the 15-liter drain bag. Next, remove line number 2, the one with the red clamp, and connect it with the heater bag. Next, remove line number 3 and connect supply bag. Open on line numbers 1, 2, 3, and 6. Next, press the green button. The display will show priming. The priming process takes around 7 to 10 minutes. When it is complete, the display will alternately flash, connect yourself, and check patient line. Wash your hands thoroughly. Remove line number 6 and connect it to the patient transfer set. Once it is connected, press the green button. The display will now show Initial Drain. After the initial drain is complete, the display shows Fill 1 of 5. After filling, the display changes to Dwell 1 of 5 and finally shows Drain 1 of 5. The process then moves on to 2 of 5 and continues till 5 of 5. The entire process can take between 8 to 12 hours, depending on the prescription of your nephrologist. The display on the machine now changes to End of Therapy. Now press the green button. The display will change to Close All Clamps. Now close all the clamps. Press the green button next, and the display on the machine will change to Disconnect Yourself. Let us now look at the process for disconnecting yourself from the machine. This is done in 6 steps. Before you start the process for disconnecting, wash your hands thoroughly. Then, disconnect yourself from the patient line. Place a new mini cap on the patient transfer set. Next, open the door and remove the cassette. After removing the cassette, close the door. Press the green button. The display on the machine will show Turn Me Off. Press the down arrow button. The machine will display the data for initial drain volume. Now, press the down arrow button again. The display will show the data for total UF. You must note this data in your record book. The process for disconnecting yourself is now complete. Switch the machine off using the power button located behind the machine. The Home Choice Pro automated peritoneal dialysis system is a compact, simple and user-friendly device that lets you undergo dialysis in the comfort of your home. You can lead a normal working life, enjoy your regular social activity and leisure, and set the dialysis treatment on when you sleep at night. The machine is small, compact, and relatively light, weighing only 11 kilograms. This means that even when you need to travel, your Home Choice Pro automated peritoneal dialysis system goes with you. One of the main risks of peritoneal dialysis is peritonitis, an inflammation of the peritoneum. According to a few published studies, automated...
So, all right, everyone, it's time for a tea break. We'll reconvene in 15 minutes. Tea and snack is arranged at the back side of the auditorium. So, enjoy your break.
Hello, welcome back. I think you have some awareness on CAPD, how we do. You got some awareness, some information regarding that? You learned something? Step, procedure and all, you learn something, no? You have any doubt in that? Okay, when I do demonstration, that time you can ask any doubts are there, okay? So now we'll do APD demo. So anything you want to ask, stop me there and you can ask me any questions, okay? So this is the APD machine, okay? This automated peritoneal dialysis or cycler. So we have here is a very simple procedure. We have only 5 buttons here, okay? Green button is a start, go button. Go, like start. Next procedure, if you want to go, you have to press the green button. And the red is a pause, stop button, okay? Then this is a select button or enter button. This blue one, no? With arrow. This is a select button or enter button, okay? And up and down arrow, you can select the programs, okay? These are the only buttons you have here. And we have a plug here inside, backside, and there's a switch here, backside. Okay, to start with, you have to on the machine, backside, okay? When you're on, it shows press go to start, okay? So now it's showing standard mode on, okay? Now press go to start, okay? So now, before starting, we have to, for particular patient, we have to fix the program or prescription according to the doctor. Okay. So you should not start. Once it comes, first go to start. If you want to start for a different patient, then you have to adjust the prescription. If it is a single patient using continuously, you need not to change every day. It will be fixed. Unless you change, it won't change. Okay. So now we are starting for a patient. Then first you have to press the down arrow now. Okay. Now you are going to fix the prescription for the patient. Okay. Press the down arrow. It shows change the program. Okay. It shows the change the program. Whatever it shows now, you have to do that. That's all. Nothing else here. So change the program. Then for this now you have to select first. Okay. You have to press this. So it shows CCPD, IPD. CCPD means continuous cyclic peritoneal disease. IPD means intermittent peritoneal dialysis. Okay. So now you have to press the down arrow. It shows total volume. Now you have to fix the total volume. What is the total volume of dialysis patient required? Usually for adult patient it will be 10 liters in the night, in between 8 to 12 hours. Okay. So you have to change the volume now. So for that again you have to press the enter button or select button. It start blinking. Okay. Now we have to press the up arrow. So we have to connect. Now I am using only 5 liters. I am not using 10 liters here. If you program 10 liters and you connect 5 liters now, it won't accept. Machine won't accept. It won't work. Okay. Whatever volume you are connecting, that volume you have to fix it there in total volume. Okay. Understood? Okay. Whatever volume you are using for the patient, that volume only you have to fix it there. You have to give there. If you give 10 liters and a program of 10 liters and connect only 5 liters, it won't work. Okay. It recognizes everything. Okay. Then it asks supply back, connect supply back, that alarm comes. Okay. So now you have to increase the volume. Press the up arrow. Now it is increasing. Make it 5,000. So now 5,000. Then you have to enter. If you don't enter now, again it will go back to 200 ml again. If you don't enter, select. Okay, you have to select it. That blink will stop now. Now it's selected. Unless you change again, it won't change until you change now. Okay. Then again after, 5,500. Okay. Then again you have to press the down arrow. Then it shows therapy time. Is a total time. Like 8 hours, 10 hours, 12 hours. Depending on the doctor prescription, different patient will need a different hours of dwell time. So we have to adjust that. Again, you have to press the select button. Then we can make it like this. So demo purpose, I'll keep 5 hours. Okay. I kept 5 hours. Okay. Then again, press the down arrow. Again, fill volume. Fill volume means out of 5 liters, what will be the fill volume? For the one fill volume. We can't fill 5 liters at a time, no? So, fill volume you have to fix it there. It depends on the patient, okay, weight. If it's a pediatric patient, we can't fill 2 liters. Okay, then you have to, it depends on the weight of the patient. So, per kg body weight, we can fill 40 to 50 ml for the patient. Per kg body weight, 40 to 50 ml. If patient is above 40 kg, then we can fill 2 liters. If it is below 40 kg, if you give 2 liters here, if patient is around 25 kg, then if you by mistake you give 2 liters, but machine won't accept, then it give alarm, it shows check patient weight, like, okay. So what if you do any mistake also, it will give alarm, okay. So now you have to increase the, again you have to press it, then you have to increase the fill volume. I'll keep it 1500 ml fill volume. Per exchange, 1500 ml goes inside and it dwells. Dwell means it stays in the peritoneal cavity for the dialysis. Okay. Again, you have to press the down arrow. Then it shows last fill volume. This last fill volume, patient who need daytime dialysis, no? Only for them you have to give. If patient will be doing only in the night and the day will be free, no? For them, you should not give anything here. It will be 0. If patient need a dialysis in the daytime, like a low transporters, they need 24 hours dialysis. So for those patients, you have to give a 1,500 here. Then what happens? Out of 3 exchanges, 2 exchange happens in the night, and 1,500 in the morning get filled inside and it stops for the day. It will be there for the day, like 8 to 10 hours in the daytime. Again, next we connect the machine in the next day. That time it drains out first, then it gets filled inside again. Okay. Now I won't give anything here. I'll give a day dwell nil. Okay, 0. Then again, weight. Again it's asking a weight. Press down arrow. See weight, patient weight. Then you have to adjust the patient weight. So again 45 kg, okay. Then again down arrow. So this is the program setting, okay. So once you set the program, you have to press the red button. Then it should show how many cycles, what is the dwell time. It will come on the screen, okay. You can see now. So total cycle 3, dwell time 1 hour 17 minutes. It automatically divides. When we give total volume, fill volume, time, it automatically divides and it adjusts automatically. Okay. Now machine is ready for the procedure. Okay. So now after this, we need things. Okay. So this is the bag. This is the 5 liters bags. So if you are connecting, you have to take 10 liters. You have to take 2 bags. Okay. So before opening the bag, you have to check what is the volume, 5 liters. Then 1.5, 2.5% concentration you have to check. Then expiry date you have to check. Any damage in the outer cover you have to check. Okay. Then you have to press and see like this. Okay. Any leakage comes in the outer cover, you should not use. Sometimes there will be some air droplets in the outer cover. That is okay because that droplets because of heat. Because this bag will be sterilized under 121 degrees centigrade and immediately they will pack it. If it is new manufacturing bag, there will be some droplets on the cover, outer cover. If it is there, nothing to worry. You can use the bag. But whenever you press like this, any fluid coming and collecting in the outer pouch, then you should not use the bag. You have to keep it aside. Okay. Then you have to check for the clarity. Towards the light, you have to hold it and see like this. You can see transparency. Clear. It is clear. If anything you saw, keep it aside. Then patient will get a replacement. Once you open the outer cover, they won't get the replacement. So before using, you have to check all these things. Okay. So this is the bag we need. And this is called 4-prong set. These are tubings. Okay. So it's called 4-prong set or cassette it is called. Okay. We need one cassette. Okay. Then we need a drain bag. It is a 15 liters drain bag. Okay. Because you connect 10 liters. So we use 15 liters drain bag here. We need this drain bag. Then we need a mini cap. This is a cap to close the patient catheter or transfer set. Okay. These are the things required for the APD. Okay. So for this also it should be done on a sterile manner. Aseptic technique you have to use. So we have to clean the machine. Okay. With the dry gauze piece or a cotton. We should not use any alcohol rub on the machine because there is a Teflon coated on this. If you clean with the alcohol rub, it will get damaged. So you have to, if you want to clean properly, you can wet the gauze piece or some cloth, squeeze it completely, then you can clean it. Once it becomes dry, then you can clean with the dry gauze piece. Okay, everywhere you have to clean. Okay, then you have to clean the table with the sanitizer or alcohol rub. Okay, so first you have to clean one table with it's towards the one side. You should not come back like this. You have to clean. Okay, so after cleaning, you have to take a bag. This bag also should be cleaned here. Okay, you have to another gauze you have to take cotton. You clean here. Okay, clean the bag. once you clean this side, you can keep it on the clean table. We clean the table now. On that you have to clip, and you have to clean here also, this side also. So here what we are doing is we are minimizing the dirt or contamination. Okay. So clean this, keep it on the table, then take cassette. This also you check, there should not be any damage. Okay. Then you clean this also with another gauze or a cotton and keep it here. Okay, on the clean table. Then we need a drain bag. This also you can open. Okay. Open, there is a clamp here on the big tube here. So this is for a draining of the whatever waste comes out now, to drain out now, this is the tube. So you have to clamp this here. Otherwise, no, once if you forget to close this, when the fluid comes in the bag, no, it comes out. Okay, you have to close this. Okay, then keep it on a newspaper. You have to keep a newspaper below, and there is a two surface here. Is a smooth surface this side, and this side is a rough surface. So smooth surface has to come upwards like this. Okay, you have to keep it on a newspaper here. So look into that now. This has to it should not come on the floor. It should be on the drain bag only, because when you are going to connect, no, it should not contaminate that. Then again you are going to touch here and all. Then there is a chance of contamination. Okay, keep it like this. Now, after that, this is the bag we are cleaned and kept. Now we are going to open it. Okay. So here need not to use any sharp things. You should not use any sharp thing here doing the procedure, because there is a chance of damaging the bag or contaminating the bag. So you can do it manually only. So there is a cut here. Okay. So you have to keep it like this, and you have to tear like this. Okay. And you should not touch it. Just open and keep it. Then this is the cassette. This also you have to open and keep it. Okay. So just open it and keep it. Then drain bag you done. So now you have to, before that you have to wear a mask. That you remember, I think. We have to wear a mask during the procedure. You wear a mask, close all doors, windows, fan should be off, light should be there. So after connection now you can switch on and open the windows, doors, everything. Till connection you have to close everything, because air should not enter. If air enters, what happens? There is a chance of dirt pushing inside. So that's why you are closing. This is a precaution we are taking to avoid the infection, because here only problem is infection, peritonitis. So avoid that, we are taking so much of prevention. Okay. So after all these things, go for a surgical hand wash or 6 steps hand wash. Okay. Then come back, dry it completely. Use sanitizer. Okay, after drying, then you have to take a bag. Okay, how you will take a bag? You should not touch the outer cover. Whatever you clean, it is not sterile. Okay, so you have to put left hand inside the outer cover, then pull the bag outside like this. Okay, like this. Then you have to keep it on the machine. So you have to keep it on the machine here. Okay. Keep it on a machine. So this is called heater bag. If there are two bags, one bag will be kept on a heater pan. Here now it get warm here till the patient body temperature. Then it starts filling. In winter, if you don't warm the fluid now, in the winter season, so if it is 2 liters goes inside, patient feel a chillness, because the fluid temperature will be lesser than the body temperature. So that's why now it warms the fluid, then it will fill. Okay, so this bag, one bag should be kept on a warmer or a heating pan. Okay, if you have another bag, you can keep it side here. Okay, on the table. Okay, if you are connecting two bags. Okay, now only one bag is there. I'm keeping on a heating pan. Okay, so now I'll keep the bag. Now now everything is ready now. Now you have to press the green button now. Okay, now it shows load the set. Whatever it shows now, we have to do that. But you should know what is that load the set means. Whatever it shows now, that meaning you should know. Then only you can do. So I'll press the green button. It shows load the set now. Okay. Set means this cassette. Okay. So take a cassette. Okay. So when the load the set comes only, na, this liver will open. Otherwise you can't open. Unless it shows load the set or end of therapy. Then only it will get open. Otherwise you can't open it. Okay. Now it will open. Okay. So this is the cassette. I told you, it look like a old cassette, tape record cassette. Okay. That has to be inserted here. Okay. So we will insert. So you can see the shape here. No? Here also there is a shape. Here is square, this is a round shape. So wherever it's there, like that only it sits. Okay. So it will sit like this now. So you should not touch in the middle. Okay. If you damage in the middle, no, then it won't work. It will show change the cassette like. If its cassette is damaged, when you start the therapy, no, it won't accept. It should change the cassette like. Okay. So you can press it in the corners. Okay. Then close the door. So tubings will come from here. Then this is called organizer. This is called organizer. This will sit on the machine here. So there is a option here. There is a cut here. It will lock here and it will lock here down. Okay. Okay. Then you have to remove this. So now you have to close all the clamps. There are 6 clamps here. You have to close all the clamps. Okay. So now load the set program is over now. Next you have to go to next program. For that you have to press green button. Okay. So press green button. Self-testing. It will test the cassette. Everything is fine. I told you, if any damage is there, then it will show change the cassette like. So it will take some 2 to 3 minutes. It will test everything. Then after that, it will show connect backs. Okay. It's a simple procedure, but you have to know that. That's all. So patients are doing themselves. Patient can do himself also. Okay. Only main thing required is aseptic, cleanliness. Any doubt here? Anything you want to ask? Yeah. What is the use of cassette? See, the fluid will circulate in the cassette only, not in the machine. Machine just like a pump. In particular time, it fills and drains automatically. In the cassette only, the fluid will circulate. Okay. That's why now we are not reusing anything here. Everything will be use and throw. Every time, every day you have to change the cassette, bags, everything. Okay. So machine only just like a pump it works. Fluid won't circulate in the machine. See, now it's showing connect bags, open the clamps. Okay. So now we have to start connecting. There are 6 tubings are there. Which one to connect to this bag, heater bag? Which tube has to be connected? Go to this now. Sorry? Huh? You can see some different colors also here. Huh? Red has to go there because red means heat, no, hot. So that's why to identify that, no, they are given red. So red has to go there. If by mistake, if you connect red tube to the supply bag, no, other bag, then it start get filled from there. What happens? No, when you connect here, first 2 liters get filled from here to patient. Okay. Then from the supply bag, no, 2 liters get filled back to this bag. So from here only it's going to fill. It won't go from other bag, second bag. Second bag is like a supply bag only. Okay. First that supply bag get empty first. Then it will get empty after that at the end. Okay. So you have to connect the red tube only to this. So you have to, before that now you have to connect this drain line. Okay. First one from the right side, first one. Okay. Is the drain, it will go to drain line. From right side if you start, first one is for a drain line. Okay. You have to connect to the drain line like this. Okay. Hold it like this. Okay. So you should be in the safe, I'll lift it. Okay. It should be, see, you can put this here and hold it in the two, in the one finger, one hand only. Both the things should be in the one hand. Okay. If it is like that, if you hold like this, no, then you can't connect, open and all. It get this thing. So you have to pull like this, open this, okay. Then you have to pierce like this, okay. Huh? You need not to lift like this, only to show you I lifting. Okay, keep it below. So second, next is red. So this will go to heater bag. Here also same thing. You have to hold it like this. You have to hold it like this, okay. You have to pull this, okay. Pull, remove and connect, okay. After connecting, what is showing? Connect bags, open the clamps. You have to open the clamps. If you by mistake, if you not open, no, again it will take some time and it give alarm that check heater bag. Check heater bag line like that. Okay. So there is a green frangible here. You have to break it also. If you don't break, fluid won't flow from here. Okay. So it's a green frangible here. You have to break it. Okay. It will break easily. Like a stick, no, it breaks like that. So we can, now the connect bags is over now. Okay. So whatever is showing, connect bags, open the clamps. You've done it. Only 2 bags because we don't have other bag here. And here, out of these things, which other tubings, which one is we are going to use? Patient line. Patient line we are going to use. Otherwise, these 3 are we are not going to use again. Okay, we have to keep it closed only. Clamp should be closed and kept it. Because you are not using, no, you have to close and keep it. Okay, and you have to open this is the patient line. If you want to connect one more bag, you can use one more white clamp is there, no? One more we can connect. At a time now we can connect 3 bag. Okay. So one more, there are 2 white clamps here. Okay. Another 2 bags you can connect. And this is blue clamp is there, no? This is for different dextrose. I think somebody may know that we have got one more fluid called icodextrin or external. Okay. It doesn't contain dextrose. It contains icodextrin as a osmotic agent. Okay. If you want to connect that bag, so you have to connect to the blue color tube. Then you have to change a program there, different dextrose. Okay. So that time what happens? The whatever dextrose fluid is there, no, that will be utilized in the night. So that icodextrin, the external will be get filled in the morning and it will stop. What is the advantage of icodextrin? That external bag? Anybody know? So this icodextrin can be kept for 12 hours for any transporter. If it is eye transporter also, we can keep it for 12 hours because icodextrin molecules are bigger in size. It's a chain of molecule. Okay. So here the concentration gradient will maintain for longer hours because it is not here osmosis is colloidal osmosis because it won't penetrate the membrane. It collides with the membrane and it maintains the concentration gradient for longer hours. Okay. Whereas in dextrose what happened is the crystalline osmosis. In dextrose fluid, no, it is the crystalline osmosis. Crystalline osmosis means dextrose crystal also passes through the membrane and enter the blood chamber. So that concentration gradient will come down very fast. Okay, we can't keep it for longer hours in dextrose. That's why I told you, no, in eye transporter we can keep it for how many hours? 4 hours minimum, maximum, sorry. Maximum we can keep it for in eye transporter 4 hours. Dextrose. I'm not talking about external. Dextrose fluid, no, we can keep it for 4 hours. But icodextrin can be kept for 12 hours, 12 to 14 hours also. Okay. Understood? Difference. So if you want to connect the icodextrin, you can connect to the blue. Okay. But in India still we don't have that bag which will be used for a icodextrin bag which is used for a machine. We have only manual bags. Because usage is very minimal here, we can't, it is we have to import that. If you import now, we can't import 100 bags, 200 bags. We have to import in a lot. So that's why it is not available here. Okay. So now what happens? Now you are using this is the patient line. From the left, first one is from the left side. This is the patient line. So you are going to use that, no? So this clamp should be open and kept again. Okay, open and keep the patient line. Whichever you are using now, that only clamp should be open. Other clamp which is not using, you have to close and keep it. Okay. Now again you have to press the green button. It will go for a priming now. Okay. Priming will take only 8 minutes. Okay. After priming, it shows connect yourself. That time you have to connect to the patient line. Okay. You have seen now in the video. So that's why I show video first, because we can't complete the cycle. Unless patient is there, it won't complete. Okay. Till priming only, connect patient, it will come. Once I connect, no, then it will give alarm, check patient line like that, because it's not connected to the patient. There is no, this thing, no fluid there, so it won't work. Any doubt here? No? Yeah. Sorry?
Where we will get the PD solution?
We have a distributors here. In Mangaluru we don't have, because we don't have much patients here. That's why we are not appointed any distributors here. We have in Bangalore, Hubli we have, because in North Karnataka we are on nearly 80 patients in North Karnataka side. In the Mangaluru side now we don't have much patients now. That's why we are not able to appoint a distributor. At least 25-30 patients are there now, we can appoint a distributor. So now we have around 8 to 10 patients from Mangalore. It will be supplied from either from Bangalore or from Hubli. So patient will take like 1 month stock at a time. So when they have 1 week stock, no, then only they'll place the order and they'll get the stock again. So it will send to transport. It will go to their house only. So in this machine, no, apart from that, we have a tidal therapy also. Is a CAPD, no, IPD, CCPD. There is a tidal therapy also here. Tidal therapy means some patients, no, they will be having a fill and drain pain. During the starting the first fill, no, they'll feel a pain inside, because when the fluid goes inside the peritoneal cavity in a force, no, it will go and touch the membrane. That time, no, they'll get a pricking pain. Some patients, not all the patients. And sometimes, no, some patients, no, they'll get the drain pain also. At the end of the drain, no, they'll get a pain, because after the fluid empty, no, the membrane may go and touch the membrane, peritoneal membrane, and it may pull like this. So that time also they get a pricking pain. So those patients now will program tidal PD. Tidal PD means some portion of the, it won't completely drain out. Some portion will be remaining inside the peritoneal cavity. It will be remaining in the peritoneal cavity. Like now we'll give tidal volume 30%. What happened? Only 70% drains out. 30% will remain in the cavity only. Okay. And it will ask every complete drain, third exchange or fifth exchange or sixth exchange, you can program. So what happens? We can't leave it for the same fluid for longer exchanges, no? We have to take out that. So you can give a third exchange, complete drain like that. Then what happens? Till 3 exchanges, that 30% will be remaining inside the peritoneal cavity. So that pain won't be there for the patient. Because it not get empty, no? So they won't get that pain. Okay. So that's why they use tidal therapy that time. Okay. And we have a pediatric mode also here. For pediatric patient, you have to change to the pediatric mode here. Okay. So for that, no, cassette is different. For pediatric patient, cassette is low cycle circular cassette will come. That you have to use for the pediatric patient. Okay. I have a question. Which are the, sorry. PD solution cost. Manual bag cost around 2 liters bag, no, manual bags. 2 liters. It comes in a 2 liter pouch. It is around 305 rupees. 305. Okay. Then this APD bags cost around 580 rupees. 5 liters. Machine is 6 lakhs plus tax, 12%. And patient get for a rental also. And there is one more option called placement. Placement means if patient have a reimbursement, then you will give a free placement to the patient. They need not to pay anything to the for the machine. From the company, they'll get a free placement. If you if you consider nowadays corporate hospital in Bangalore and all, now it is 4 to 6,000 rupees per sitting. Like in Manipal Hospital or Apollo Hospital or Fortis, it is more 4,000, 4,500, 5,000 rupees they charge. Okay, if you consider that, PD is cheaper because manual PD, not APD. APD is much higher because it need a cassette and all. Okay. Here now manual PD comes around now at present 35,000 rupees per month total. Per month cost will be 35,000. For APD it is 65,000 rupees because this cassette only now costs around 780 rupees. That cassette. So that has to be changed every day. Okay. So I have a question. So who are the patient we can select for PD? Sorry? Huh? Huh? Okay. Then? This is a misconception, okay? Not only for vascular access patients. It can be start for everybody. All the patients, starting from newborn to any age group. Okay, only patient who have abdominal surgeries, most surgeries. So they are contraindicated. Other than that, we can use for all the patients. Okay, so, because in India it's happened like that. Only for access failure patient who are bedridden, patient who are not able to come to stay far away from the dialysis center. Only those patients who are getting in India now. But if you give PD for the patient, start early for the patient in the beginning itself, we can prolong the life of the patient. Because in PD, because of residual renal function, it preserves the, I told you, it is preserves the residual renal function. What is the advantage if you preserve the residual renal function? Sorry? Quality of life will be increased. Why? How? Sorry? No. Okay. No, I'm asking how residual renal function, if residual renal function remaining in the kidney for the patient, what is the advantage for the patient? Sorry? Huh? Less restriction, good, correct. Then? Correct, good. Then? Sorry? Two main function. Sorry? Tell me, no problem. Water removal, fluid removal. Then? Huh? Electrolyte balance, okay. Then? Yeah. So what you call that? You are telling that removal. For removal, what you call in medical term?
Clearance.
Excretory function, no? It does excretory function and endocrine function. Okay, it does excretory function, endocrine function. So what is the advantage of residual renal function remaining? Then now, can you tell? What is the advantage now? Yeah, the endocrine function will be remaining for the patient. No dialysis can give endocrine function. Erythropoietin section will be there. Then blood pressure control will be there. Then the vitamin D absorption, it helps in vitamin. Those things will be there. So that's why now quality of life of the patient will be good. Okay, and patient like in hemodialysis, what happens? Continuous hemodialysis after 1 year, 2 years, 4, 3 years, what happens? Patient deteriorates, he'll become weak, thin, and become pale. Okay, in PD, there is no much stress on the body, so you look like a normal person. So the quality of life will be good in the PD in the initial stages. So then you can anytime shift over to HD, you can shift over, you can preserve the axis also, so that his life can be prolonged. Okay. So now it's showing connect yourself. Okay. Now it's showing connect yourself. Now you have to connect. So you can see some fluid is here. It done the priming. Okay. Huh? So now you have to connect to the patient line now. So this is the patient line, okay. This is the catheter. Till here it is the catheter, okay. And this is the adapter, titanium adapter. In between the catheter and this is called transfer set, okay. This is called transfer set. In between the catheter and the transfer set, there is an adapter called titanium adapter. It's made up of titanium metal, okay. So it's made up of titanium metals, okay. So what is the advantage of this? One, it prevents the infection because the catheter end is not exposed here. See, catheter end is covered here. So there is no accumulation of dirt here, okay. Second thing is, when if patient is want to go for a MRI, CT scan, you need not to remove this, okay. It's a titanium metal, or it won't react, okay. So this is the transfer set, this is the titanium adapter and catheter, okay. So now we are going to connect, okay. So we will take this line, patient line. It is 9 feet long, okay. 9 feet long it is, okay. If patient wants to go for a washroom after connecting, he can go along with this. But there should be attached bathroom in the room. Otherwise, he has to keep this machine on a trolley, not your dressing trolley, steel trolley. They can move and go also, okay. So but they can't disconnect in between. They can do that also, but contamination chances are more. In India, we don't advise, but in abroad, there will be a extra connection line also comes. They can connect extra line and they can go for this thing, washroom and all. Okay. So now we are going to connect this. Again now you have to, this has to be in the right hand always. If you are a right hander, this connection will be in the right hand and this you have to hold it in the left hand, okay. So what you have to do, first you have to pull this. You should not pull like this and all, okay. You should not contaminate that end, okay. Hold like this and pull, okay. And you should be near to the transfer set or patient catheter. Pull like this, open this, okay. You can connect like this, okay. You should not touch this blue tip, okay. Then you have to open for the drain, okay. Here is, you have to hold it here, you should not touch this connection. So your finger should become like this, okay. When you're going to hold the transfer set now, you have to, in the two finger you have to do like this, hold it and open this. When you come here now, you can try this, okay. Open here, okay, then keep it on the sterile napkin, okay, and open the clamp here, okay. Now you have to press the green button again, okay. It go to initial drain first, okay. If fluid is there or not, first it tries to drain out first, okay. First it tries to drain out, then it goes for a fill again, okay. So still, since now you are not connected to the patient, from here it won't pass. It will give alarm now. Check patient line like that, okay. So this is APD. Any doubt here? After some time, now it give alarm. Check patient line like that. Okay. So this is APD. Any doubt, you can ask me when you come here to see manual CAPD. Okay. Now we will start manual CAPD. 10-15 people can come in a batch so that we can do manual CAPD. So this is a catheter, okay. So it's called swan neck catheter. You can see it's a bend, permanent bend here. It's called swan neck catheter. Usually in India we use this catheter only, and we have straight catheter also. It will be straight like this, and we have a coiled catheter. Coiled catheter means no tip will be coiled, okay. So there are 3 types of catheters. You can use any catheter. In India, we are using mostly in the most of the center we are using this swan neck catheter or coiled catheter. Okay. So what they do, they will open here, right or left side of the umbilical. No, they will open. They will insert the catheter like this. It will go to pelvis here. It should be in the pelvis. If it is lateral, no, like this or this side, that side, then there will be a drain issue because it won't be touching the fluid only. It will be upside, no? So it won't be touching, so fill will happen, but there will be a drain problem for the patient. So it should be in the correct position in the pelvis. There is a Douglas pouch, you call, no? There it should be, the tip. Then drain will happen easily, okay? So they place a catheter. Then there are two cuffs here, you can see, no? There are two cuffs here. Okay, one cuff is sit above the membrane. Peritoneal membrane they open, no? There it will sit here on the peritoneal membrane. What happens now? We give, I told you, we give 14 days break. Okay, break in. So that time now it gets fibrous. Fibrous means tissue will grow on that. Okay, then it will get fixed here. Then this U bend is there, no? This U bend. U bend, no, they will pass under the skin. They make a tunnel under the skin. Then they will exit out like this. Okay. When they exit out, this cuff, now second cuff will sit below 2 centimeter below the skin. 2 centimeter below the skin, so that it will get fibrous inside again. So two places it get fibrous and hold the catheter. It won't come out easily. Okay. And also it prevent infection. Okay. The cuff benefit is, one is prevent infection and holds the catheter in a place. So then they will exit out like this. Okay. So this much of the tube will be outside the body. Okay. So for that we will provide a belt or a pouch. They have to tie it over here, and they can keep it. They keep the, whenever not it is used, no, they can keep it here in the pouch, wear a dress, and they can do their normal activities. You know, no, they can for PD they need not to lie down for 4 hours or 6 hours like that. So it take only half an hour procedure. After that, he is like a normal person. He can do his normal activities. Okay? Understood? So now, this is the catheter. This is the catheter. This is the titanium adapter. Okay? In between catheter and the transfer set. This is called transfer set. So titanium adapter and catheter is permanent for lifetime. They can use for lifetime. Only this transfer set will be changed once in 4 months. Because we are using this so many times every day. So this may get wear out. So we will change the transfer set once in 4 months. For that changing also, no, patient should not do. Technician will go and do that. Because we have to do it in a sterile technique. Okay. Otherwise there is a chance of contamination. Okay. So this is about the catheter and transfer set adapter. Okay. And we require a bag. This is a 2 liters PD bag. In APD we use 5 liters because here we are not going to change every time, no. So here we need a 2 liters PD bag. Okay. For this also, no, you have to check before starting, no. We have to see the doctor prescription 1.5, 2.5 like that. So take that bag, check for places. PLACES. P means pull ring. Pull ring means this. You have to pull it, no. This is called pull ring. This should be intact. If it is open, you should not use the drain bag. Sorry, you should not use the bag. Okay. L means, sorry. Okay. Secondly, L means leakage. Okay. So you have to press and see. Any fluid comes here in the outer cover, you should not use the bag. Okay. You press and see like this. Okay. A means amount, volume is 2 liters. Because we had before now 2.5 liters also. Abroad now patients use 2.5 liters bags. Abroad because their height weight is more. I told you no, depending on the weight we can decide the fill volume. If patient is not getting clearance, proper clearance in PD, when he is doing 3 or 4 exchanges also, then we can change the prescription. We can increase the fill volume. Okay. We can decrease or increase the dwell time. Like that we can adjust. Okay. So that time we use 2.5 liters for few patients. Okay. So how it will help for the clearance when you increase the fill volume? I told the patient is will be built is heavy, no? Height and weight is more. So that time his peritoneal cavity will be more only. Okay. When you fill the 2 liters, it won't completely filled. The peritoneum is not completely covered. When you, so that you won't get the good dialysis. Okay. When you fill 2.5 liters, the peritoneal cavity can be filled completely. Or 3 liters also we can fill for them. So when you cover complete peritoneal cavity, then he'll get the good clearance, that patient. Okay, that's how it happens. Okay, amount, okay. C means clarity. You have to see towards the light like this, see, this clear. You can see, this clear, okay. E means expiry date. You have to check for the expiry date. S means strength, 1.5, 2.5. Okay. So you have to check this. Before that, now you have to clean the table with the sanitizer or alcohol rub. Okay. Then you have to clean this also. After cleaning, you can keep it on the clean table. Then clean this side also. Towards one side only you have to clean. Okay. So this is ready now. Then we need a blue clamp. Because this tube fill line doesn't have a built-in clamp there. So we are using this clamp. So all these things now, only this thing will be reused here. Okay, because we are not using anywhere now. So we will clean this also. Take another gauze, sanitizer, clean this completely and keep it here. Then you have to take 2 mini caps. So we require only one, but you are keeping 2 mini caps. Why? While opening, no, patient it may get fell down, or this mini cap will contain a betadine swab inside. So you can see betadine swab inside. Okay. So sometime there is a chance that betadine swab might have come outside. That time you can't use that cap. So for emergency purpose, you have to keep 2. So one, if it is not usable, then you can use another one. Because patient is doing himself, he can't go and take it from the box again. So you have to keep it 2 always. Okay. So this also you have to clean. Okay. Keep it on the clean table. Okay. Then you have to go first, before that, for cleaning also, first you have to do general hand wash. Then you have to do all this procedure. Okay. After cleaning, now is ready for the use, no? So now you have to, I told you, you should not use any scissors because are sharp things. So there is a cut here. So you have to hold it like this. Okay. Then you have to open like this. Okay. So now you are not able to, you should not touch it again. Still your hands are not clean because you have cleaned everything. So now you have to go for a 6-step hand wash. Before going, you have to, transfer set will be there, no? That you have to pouch, from the pouch you have to open and keep it outside. On the pouch only. Okay. Keep it outside. Then go for before going also you have to keep one newspaper below. One newspaper you have to keep. Okay. After that you can't keep. Once you do surgical hand wash, you should not touch anything. Okay. You should not contaminate your hands. If you contaminate, again you have to go for a wash. And you should not use a mobile phone or anything. You should not touch anything. You should not touch the ears, cloth or anything. If you at all touch also, no, you have to wash it or you have to use a sanitizer again. Okay. Then go for a 6-step hand wash. Come, dry it. Okay. Use sanitizer. Okay. Rub it. Then you have to take a bag like this. Okay. You have to take a bag like this. Then you have to hang it in the, sorry, I forgot to tell, this also you have to clean. IV stand also you have to clean with the sanitizer. Okay. Then there is a hole here. You have to hang it here. Okay. Okay. So after that, you have to, there are 2 bags here. Okay. Let it be there only. Only tubings you have to pull it down like this. Okay. And this end is there, no? This Y junction, it's called Y junction. This you have to hold it in a left hand or right hand, depending on your use. If somebody uses left hand, somebody uses right hand. Okay. Hold it like this and you uncoil the tubings. Okay. You have to separate the tubings. See? There are tubings get attached here. You have to separate it. Okay. Separate it. So, but you should not leave this down. If you leave this down, what happens? It gets contaminated. Somewhere here and all it touches, get contaminated. This only goes and connect here. So, the contamination chances are high. Okay. So, then you have to pull down this bag. Okay. So, you can see there are surfaces here. You can touch and see. Yes, smooth here, rough it is. Back side is rough. Okay. In middle, no, it is smooth. Here and all is rough. Back side completely rough it is. Okay. Middle it is smooth. Okay. So you have to keep this bag up. The smooth portion should come upwards on the ground and the newspaper. Okay. So before you have to keep our newspaper here. So you have to drop it here down. Okay. Okay. Huh? Now, fluid is not flowing from here. No. Why? Because there is a seal here. It's called green frangible. It's called green frangible. There's a seal here. So, fluid is not coming out from here. Unless we break, it won't come out. So, before breaking, no, what you have to do, you have to clamp the fill line. There are two lines. One is liquid line, and one is a drain line. This is called fill line, this is called drain line. Okay? So, you have to clamp the fill line. Okay? So, it has to be clamped like that. Anywhere you can clamp in the fill line. Okay? Now, we can break the green frangible. Okay? So, you can do like this, see? It's broken inside only. Now, if you open the clamp, it will flow. Okay? So, next step is connection. Okay? Next step is connection. Okay? This is the main thing. If you do any mistake here, now only fluid will last. Okay? If you do mistake here, there is a chance of infection here. So, you have to hold it like this in the right hand, okay, or left hand if you are a left-hander. Okay? And you have to hold closely. It should not be like this. Length. Then now when you are opening and all, it may touch somewhere else. Okay? Hold it closely. Come near to the, you can come this side. So, you have to open this. Okay? You have to pull like this. Some people not do like this. Some people like this and all should not do. Because we should not contaminate that end. Okay? So, pull it like this. Okay? Then this is a transfer set. See? My fingers, see? These two fingers will be free. See, open this. You can see. Okay? This is the wasting. You drop it. Okay? Then connect like this. Okay? Huh? Connect like this. Okay? So, once you connect, you can leave this hand. Okay? Then, you have to, when you are going here, now your finger should become like this. 2 fingers technique it is. Okay? So, you have to hold it in the middle here. Then, another 2 fingers here, and you have to open for a drain. First, you have to check for a drain. If fluid is there or not, you have to check for a drain. If fluid is there, you have to leave it for 20 minutes. If pre-filled fluid is there, that has to be left for 20 minutes. So, in 20 minutes, it drains out completely. Okay. Once it drains complete, now how you will come to know drain is completed? So, what you have to do after 20 minutes or 15 minutes, you have to press the tube here. So, air bubbles start coming up from the below. That indicates that drain has stopped. Okay. Okay, after 20 minutes. So, once that drain has stopped, you have to close back this. Okay. Then keep it on the napkin. Now, we have to fill the fluid inside. Before filling, we have to do flush before fill. Why? You can see air bubbles here. So, machine has done priming, no? Like you have to do flush here. Okay. How we will do the flush? So, we will close back here. Okay. So, air bubbles should not go inside, no? So, we locked it here. Now, what I will do? I will hold it in a left hand. This drain line. Okay. I will open the clamp and give 5 seconds. So, 5 seconds means we can't do that, no? So, for the patient purpose, we want to tell, they ask them to count. Like that 1, 2, 3. We will ask them to count 1001, 1002 like that. Because 1, 2, 3 means they do 1, 2, 3, 4, 5 like that. They think that no fluid get wasted. But you have to do, this is the important step. It has to be done. Because it not only removes the air, it avoids the infection also. Because while connecting, now it gets exposed. There will be some dirt accumulating on the blue tip. No? So when fluid passes like that, it wash out that contamination. Okay? That helps in the prevention of infection also. So what we will do now, I will hold it like this, I will open and I will count 1001, 1002, 1003, 1004, 1005. Then I will crop it. So they are given for flushing now, they are given extra fluid like 80 to 100 ml, extra fluid will be there. You should not think that now it will be waste. So patient thinks like that. It will get, oh, why should we waste? Then they will close it very early. Then the flushing won't happen properly. Okay. You have to give 5 seconds. Okay. Now you can see now there is no air bubbles now. So now it is not going anywhere because we are closed here also. We are closed here also. Now we have to open here. Okay. So while holding the transfer set, you have to, your hand should become like this, 2 finger. So you have to hold it like this. See, like this, and you have to open this. When you open this, it starts filling now. I capped here, otherwise it comes out. If patient is there only, you can use. Okay. So it gets filled within the 8 to 10 minutes. In 8 to 10 minutes, it gets filled. If you raise the height now, it make more height. It goes with gravity. Okay. So you can keep it height now. It will go within 7 minutes also. Okay. It gets filled within the 7 to 10 minutes. Once it gets empty, you can leave it for a longer time also. Air bubble won't enter because it's a closed system. So at the end, fluid will come and stop somewhere here in the tubing. Okay, it won't enter, air won't go inside. Okay, if you leave it for half an hour also, it will stop there only. Okay, so once it empty, then you have to close back this, close it back. Okay, then this is the cap. We are not using the same cap. Here nothing will be reused except blue clamp. Okay, this is the cap. Okay, you have to see for the damage here also, the expiry date. You check expiry date. Okay, if people are able to see, you can come this side, I think. Some people can come and see this. Okay. So you have to open this. So opening also you have to keep it on the table only. For your sake now I am opening here. Okay. You have to keep it and do it. Otherwise it will fall down. Okay. So here there is a flap. Okay. And you can see here now is a cup like here. Okay. Here it is a plane. So this has to come down. Okay. So that cap will sit in that. Otherwise there is a chance it fell down. So open like this, okay. So keep it here. After keeping now, you have to check, put a sanitizer, okay. Then you have to see for the betadine swab inside, okay. So you should not lift and see like this. You have to see like this only here and keep it below. For you, I am showing there is a betadine swab inside. You can see, okay. Betadine swab is there inside, okay. So if it is betadine swab comes out, you should not use that. Okay, if it is fell down, you should not use that. Okay, so keep it open and keep it ready there. Put a sanitizer. Then you are going to disconnect the bag. Okay, so you are going to disconnect like this. This is waste, no? Sorry. I have to see. I told you no. You have to put a clamp here because there will be a fluid in the tubings also. So you have to put this clamp here. And this thing, then you have to disconnect now. Okay, disconnect. Then you have to take a cap and close it. Okay, then keep it in a pouch. Then patient will be free for 4 to 6 hours or 8 hours depending on the membrane. If it's a high transport membrane, 4 hours. Every 4 hours he has to do one more procedure. Drain, again fill. This is called continuous. There is no break. It is not that now drain and give a gap and do. Once it is drained out, he has to fill it. If you disconnect now, then that fluid is waste. Again, he has to use a new fluid. Okay. So this is the procedure. Okay. Then patient will be free. He can do his normal activities, keeping in the pouch. Again, he has to repeat after 4 to 6 hours or 8 hours. Same procedure with the new things. Okay. Any doubt? Yeah. Sorry?
In manual, patient will move freely.
Sorry?
In manual, we are doing PD. That time patient will move freely.
Correct.
But in automated...
APD, that's why it will be done in night while sleeping. If you want to go to washroom, if there is an attached bathroom, the connection will be 9 feet. He can go with the connection and come back. And he can sit, he can eat after connection, no? And that 9 feet is there, no? He can move around also. He get up and move around also. But he can't do like a normal person. There should be some, you have to adjust for something because he is not a normal person. Okay. So PD is every time you have to do every day 3 times a day, no? So you won't get 3 times in a daytime. So wherever he is, he has to come back and do. And one more flexibility is there. If patient goes to some function after filling, he is supposed to come by 4 hours and do one more exchange, but he is not able to come. It become 8 hours. Nothing to worry one day. Nothing will happen to him. Okay, he can come and continue the dialysis, but it should not be done every day. Okay, that flexibility is there. Okay, during traveling, without filling also he can go, then he can start there, or fill and go there. Like that, he can do according to his schedule. Yeah, that is the advantage here. And he can plan his dialysis. Okay.
What is the restriction of fluid intake and dietary.
Fluid intake.
Same as HD or different?
Fluid intake is every day we remove. Every day we remove, no?
No, we are
Sorry?
taking water intake and.
That's what I'm telling. That's what.
That,
I'll tell you. So here in HD you'll do alternate days, no? Once in 2 days. Here you will do every day. Okay, we'll remove some fluid, no, every day. Like in PD, one exchange, no, they'll get around 400 to 500 ml output in one exchange, extra output they'll get. Once you fill that drain out, they'll get 400 to 500 ml. So 3 times they do. Around 1200 ml they'll get. If they have some residual renal function, they'll pass some 400, 500 urine, some almost around 1700 to 800, it will come out per day. Out of that, they can drink 75%. Whatever the output is there per day, in that 75% should be a intake. And in food, the restriction is not much. If they are diabetic or hypertensive, then they have to avoid the sweets and salts. Salt and sweet only the restriction. And fruits. Fruits should be the restriction because potassium will increase otherwise. So only those restrictions. Other than that, they can eat everything. They can eat, we recommend them to eat good protein food like chicken, fish, egg white, okay, dal, soya. So we recommend that. They have to take a good protein food. Per kg body weight, they have to eat 1 to 1.2 grams of protein. If patient is 50 kg, he has to eat around 60-70 grams of protein per day. Okay. Then, okay. Any doubt you can ask me, otherwise we can go.
PD, if patient don't have diabetes, they will get diabetes.
It is not like that. It is not like that. They won't get. Usually, see, diabetic, if you eat sweet, those patients don't, everybody won't get diabetes, no. If you eat sweet also, all the people won't get the diabetes. Okay. So they may get developed after some years.
Because that
Some years.
solution conduct high dextrose.
Now that's why now we use low dextrose and no dextrose. That icodextrin I told you, no. Doctor will advise low dextrose and no dextrose and the icodextrin. It doesn't contain dextrose. So we can prevent that also. Yeah. So manually you have to vomit. Manually. You have to buy hot water bag before starting the procedure, no. You have to keep it on hot water bag without opening the cover. You have to keep it on the bag, hot water bag, or you have to buy that eating pad comes, no, for orthopedic pain, eating pad. And that you can keep, dry it. Or you can keep it in the sunlight for half an hour. Then you can use. Okay. Manual. Yes. Every time you have to change the minicap. Yes.
Per day about
3 to 4 minicaps you require. 3 bags you require, 3 to 4 minicaps required. Yeah.
Supply bag is 10 liters.
10 liters.
Generally.
Yeah.
So there are 2 bags basically, this one and that
Yeah.
supply bag. So you're telling that this only after matching the temperature, that fill volume, after matching the temperature,
Yes.
this fill volume of 2 liters
Will goes to patient body.
the
Yes.
first exchange.
Yes.
So that will go to the patient and simultaneously that 2 liters from supply bag will come
Get,
back.
yeah.
These 2 bags are interconnected.
That's what, no. See. It will happen in the cassette.
This bag, another bag was there.
Correct.
That was the supply bag.
Correct.
So how these both bags are connected?
That's what I told you, no. At the tubings, that lines are there, no, in the catheter.
This, one clamp will be connected to that supply bag.
No clamps or nothing. It automatically manages here in the cassette. The machine automatically manages that. There's a line.
There will be a connection to the supply bag also.
Supply bag, there's a connection. No, these tubes are there. No, we'll connect one here. See, this at a time we can connect 3 bags. Okay. Yeah.
now you told that 3 bags at a time we can connect.
Ah.
But every bag should be kept on that pan.
No. See, now only I'll explain to him.
That like
I'll tell you.
we have
See, from 2 liters goes from here to the patient cavity. Okay. What happens after that? From supply bag, no, 2 liters get filled into this. It is not from there; it directly goes. Okay.
okay.
Automatically it does. Once 2 liters goes there, 2 liters get filled here. Yes, yes. Again 2 liters goes, again it goes from here. Like that. Yes. No. Yes. If you connect by mistake, if you connect red clamp to that bag, then it will go from there. It won't go from here. Then it will go from here, then it will come from here like that. Reverse it will happen. Okay. So this is a manual bag, okay. For this also now we have to do all the things like cleanliness. First we need a table, IV stand, okay. Then patient cot or a chair to sit for him, okay. Then we need a bag, PD fluid we need, okay. Then we need this blue clamp. This blue clamp we need, okay. Then we need a cap, mini cap. This one cap filled down there. So everything will be changed every time, okay. These are the things we require. First you have to clean the table, okay. So take a gauze or a cotton with sanitizer, clean the table towards one side, okay. Once you clean that, then you have to clean the cap, okay. You have to see damage or expiry date, everything you have to check. Clean this with another gauze piece, keep it on a sterile this thing. Then we need to it's already open now, so if I open that now, it will come out. So this is the clamp, okay. Here these things, only clamps will be reused because we don't have a built-in clamp in the fill line. Only in the drain line it is there. So fill line we are using this clamp. So it can be reused after cleaning, okay. We will clean this also, then we will keep it here. Okay. Keep it on the table. Then we'll take a bag, okay. So this bag will be inside the pouch, okay. I will remove that inside the pouch, okay. So it will be the coil, the bag and all will be coiled and kept it in this, okay. So you have to clean the outer cover and you have to check for the things, expiry date, volume, leakage, clarity, and this pulling should be intact. That has to be checked. Clean the bag, both the side, and keep it on the clean table. Okay. Then you have to clean the stand also. Okay. Because this also there will be dirt, no? You have to clean. So we are doing this to avoid the contamination. Precaution it is. Okay. Then after cleaning everything, we have to tear the bag. I tear, no? Like that you have to tear it, keep it. Then go for a hand wash. Before going, you have to keep one newspaper below. Okay. To keep a drain bag. Okay, so after that, go for a 6-step hand wash. Okay, then come back, dry it, put a sanitizer. Okay, then take a bag and you have to hang it. Okay, so you have to hang the bag here like this, and this will be attached here. This will sit like this, and tubings will be here, coiled and kept here. You have to uncoil the tubings, and these two tubes now get attached like this. You have to separate the tubings. While separating now, you have to hold this. You should not leave this down. If you leave it down now, it get contaminated. So, okay. So hold it, you take this back, and you can see there is a smooth surface here and the rough surface up and down. Okay. Here back side also you can see is a rough surface. Okay. So smooth surface has to come upward. Okay. You should not touch the ground. Okay. You have to drop it like this on the newspaper. Okay. Then after uncoiling, first you have to clamp the tube, okay, because without clamping, if you break this now, the fluid will get wasted, it will go to drain bag. So you take a clamp here, you can clamp it anywhere in the fill line, okay. So take it like this, hold it like this, and you should clamp it like this, okay. So it should be straight. If you put a cross, no, then it start leaking out. Okay, it should, we provide 2 clamps actually. If they are not put properly, no, they put one more clamp. 2 clamps they'll put. Okay. So put a clamp, then you have to break it here. Okay. This being frangible, it will break inside only like this. Okay. So break, then connection. Okay. Connection is very important. Okay. So connection, what you'll do? So you have to, if you are a right-hander, it should be in a right hand. If you are a left-hander, it should be in the left hand. And it should not be held in the same hand like this. If you open like this, no, you can't connect again. So, okay. So one should be in the one hand, other should be in the other hand, like this. So hold it like this. Come near to the transfer set. Open. Okay. Hold it in the two fingers like this. You all other three fingers should be closed, because if you open now, you may tend to touch it. So hold it like this, and it should be 45 degrees downwards. Okay. Then open it like this, and you can connect like this. Okay. Once you connect, then you have to open for a drain. Any drain comes from the peritoneal cavity. Okay. If fluid is there, it will take 20 minutes to come out. Okay. After 20 minutes, you can hold the drain bag like this and press the tube like this. So air bubbles start coming up from the below. That indicates that drain has stopped. If drain is there, it will go down. Okay. Once drain is stopped, then you have to hold it like this. You should not hold it with the 5 fingers. Only 2 fingers has to, when you go there now, it has to become 2 finger. Okay. So you hold it like this, close this. Why you are closing? We have to do flush now, because it will be having a air droplets here. Okay, air will be there. So that you have to remove it by flushing. Not only removing the airway, it clears the dirt in the transfer set here. When you open now, there will be some dirt accumulate on that. When you do flushing, it get washed away. Okay, it helps in the prevention of infection. It's called flush before fill. It's called flush before fill. Okay, after drain, you have to close this. Okay, after drain, you have to close this. Then keep it down, and this will be opened. Okay, this will be open in the drain. Okay, then what you have to do? One hand you have to hold it here and open this and give 5 seconds. How will give 5 seconds? You have to count. Like now 1001, 1002, 1003, 1004, 1005. Now where will get flushed away to that drain bag. Okay. So now we are going to open the transfer set. Okay. So when you open the transfer set, it starts filling inside. Okay. So I clamped it here. Okay. Otherwise it comes out. So the fill will take only 10 minutes, 8 to 10 minutes. Okay. Once it gets filled, completely it becomes empty. If you leave it for more time also, no, air won't enter because it's a closed system. Fluid will come and stop somewhere here. Okay. So then you have to, once it gets filled, again you have to close it back. Okay. Then you have to put a clamp here because there is a fluid here. No? When you disconnect, it will come out. So you have to, first time I have done like that. That's why it has come out. Okay, you have to clamp it here. While explaining, no, I forgot that. Okay, clamp it here. Then you have to take a cap. Every time you have to use a new cap, no? I told you. So you have to see for a damage or the expiry date. Then everything is fine. Then you have to open it. There's a slit here. And this portion has to come down. This portion has to come down. Okay. So keep it on the table. Open it. Okay. When you open, you have to see for a, like this only, no? There only you have to see. You should not lift and see like that at all. Okay. See like this and keep it there. So you can see now, there's a peritoneal swab inside. For this you have to see. So usually we keep 2 caps. Because sometimes now this peritoneal swab will come out. Sometimes it won't be there. Sometimes it fell down. So patient can't go and take the cap from a box again. Because it will be connected. So you keep 2 caps always. Okay. So after that, seeing that you will keep it in the that pouch only. Then you have to hold it like this. We disconnect. Okay. Disconnect. And we will cap it. And it should be 45 degree downwards only. While disconnecting, connecting, no, it should be 45 degree downwards. Nobody asks why. I am telling from 2 batches now. Why you should hold it like this?
Fluid outcome.
Sorry?
Fluid outcome.
No. Now it's closing, no. Where fluid will come? Now if you keep it like this, there is a chance, no, dirt can enter. So dirt comes from up to down, no? It is not coming from down to up. So this is the precautions we are taking. Okay. So that's why they tell hold it 45 degree downwards and clamp it. Then you can keep it in a pouch. Okay. And you will be free for particular hours. 4 to 6 hours, 8 hours, he can do his normal activities. Okay. After that again he has to repeat the same procedure with us new things. Nothing will be used, only clamps will be used. that clamp. Okay. Any doubt? In APD, any doubt? Anything you wanted to ask?
In brain, we are having one more this clamp is there.
Yeah, that is to take a sample. If we want to send a fluid for sample, drain liquid, then you can take during the procedure itself.
In case of peritonitis, like
Yeah,
CAPT peritonitis,
yeah.
we have to give intermittent dosing of
Intermittent, yeah.
how to give that.
So this is called, it is a port, injection port. This port is called injection port. Okay. Through this we will give a injection, antibiotic. So mix it, then you will fill it inside. So for this also there is a procedure. You have to use a new syringe. If you are giving two antibiotics or antibiotic with heparin, then you have to use two syringes. You can't mix it and give it in one syringe. Okay.
Everything like if we are
Everything
giving
we can mix to this. Like
Yeah.
antibiotic.
Antibiotic can mix everything. Okay. So there is an antibiotic, no, two antibiotics you can't mix. There will be some reaction happens, no, like vancomycin and ceftazidime can't be used in one bag. So that time you have to use different bags.
Like one session after.
After first session one injection, second or third session another injection, like that you can use. And also if like ceftazidime and amikacin, ceftazidime and sulfazoline, that we can give together, both in one bag only. Okay, so that we can do. So here also now you have to use different syringes. Once you take from the vial, no, draw the injection from the vial, then you have to change the needle before pricking to this. There should not be a second prick here because it may contaminate. So before pricking also now you have to take a sterile gauze piece, betadine or a sanitizer, and you have to scrub this port. Okay, because there is a chance some contamination will be there. When you prick, it may go inside. So you have to change the needle after taking the drawing from the vial. You have to change the new needle. Then you have to scrub the port. Then you have to prick it and push the injection inside.
we are giving heparin together, then a needle will be there only. We have to change the syringe.
Sorry.
Suppose we are giving heparin also.
Ah.
So that fresh needle we have put there. Now
No,
we will
not
change
put there. Different syringe you take. Different needles you take.
different needle we have taken.
Yeah.
Now the new needle we have placed there.
Yeah.
To,
Prick there.
give the
Yeah. Correct.
antibiotics and heparin.
Yeah.
So that with the same needle we can give antibiotic and heparin, or we have to change the needle again.
No. You have to change the needle. Okay. You should not reuse anything. You should not say, there should not be any second prick there. Every time, see, one syringe you will take heparin, one syringe you take a antibiotic. First we give antibiotic, then we will mix it, then you take another syringe, change the needle again, you have to prick it and give a heparin and mix it again. Okay, here also it has a port here. In APD also, you can give it. And this is called, this is a catheter, okay, swan neck catheter, and there are two cuffs. It helps in holding the catheter and also prevent the infection, okay. And this is a titanium adapter in between the catheter and the transfer set. This is called transfer set, okay. So there is a sleeves here. It covers the catheter tip here. If it is open now, there is a chance that dirt may accumulate here. So these sleeves will cover that. So there is contamination will be prevented here. So, and this is a titanium metal for MRI, CT scan. If patient goes, no need to remove it. That's why you are giving a titanium adapter here. And yeah, this will be changed once in 4 months, because we use so many times now, open, close, it may get wear out. If it get wear out now, it start leaking from here. If you close also now, fluid will be leaking here. So we will change once in 4 months, and it will be done in a sterile technique by a technician only. Patient won't do this. Okay. So this is that transfer.
Titanium adapter is inbuilt with the catheter.
No. It is separate. You have to buy. Catheter is separate, and it comes with catheter comes with a plastic adapter. Then you have to change with this. This will cost around 5,700 rupees.
That is like our updation which we are doing
Yeah.
for patient.
For what?
This titanium.
No. It is compulsory. Yes. No, it won't come with. They have to buy.
Have to,
Patient has to buy, and we'll connect.
if plastic is there,
Plastic also you can use, but it won't come for longer time, no? And it won't cover, no? This tip won't be covered there. because it will be open. This tip, no? Plastic adapter, when you put these sleeves won't be there on the plastic adapter.
It will be open.
Open only like this, it will be. Plastic adapter will be like this only. Okay. So better to give this, otherwise no, that plastic adapter also goes sometime. So again you have to change that. That's why now we are not taking any risk. So patient will be doing at home, no?
Yeah.
So we won't be seeing every day. So it's better to, we can do with plastic, but we should take care of this. Yeah, this is better.
Regulator is this part, sir.
Sorry?
Open and close.
Yeah, this is the valve for in and out. This much only it will open. Close, it will lock here. And this is for connection.
That is for connection.
Yeah.
How long can you use this adapter? Titanium adapter?
Lifetime. Catheter and adapter for lifetime. No need to change. Transfer set has to be changed once in 4 months. Yes.
So from where the exit side comes, sir?
Exit site, huh?
Yeah.
See what they do, this portion will go inside the peritoneal cavity, okay? So left or right side of the umbilical, now they open and they'll insert like this, okay? So insert on the above the peritoneum membrane, no, it will sit here in a rectal sheet, okay? Okay, it will sit here and we give 14 days break-in. No, that time it gets fibrous. Tissue will grow on this and it will get attached here, okay? Then this bend is there, no? This, they make a tunnel here under the skin. Then they'll exit out. This cuff, the second cuff will sit below 2 centimeters the skin. Okay, there also it gets fibrous. So this cuff will help in the fixation and prevent the infection also to entering into the cavity. So it will become like a permanent thing. It won't come easily. Okay. Sorry?
Acute catheters.
Acute to use stiff catheter. This is a soft catheter. It won't cause any allergy, pain, irritation to the patient. Okay, a stiff catheter can't be kept for longer days, no? Yeah, like months.
So in acute catheters, there is no break-in time, right?
Sorry?
So in acute catheters, there is no break-in time, right? It is used immediately, right?
Acute means you want to do immediately, no? That's why, yeah.
What about the leakage chances?
See, in acute cases, what you do, immediately after catheterization, immediately they start doing. But here we give 14 days time. So I told you, no, it gets fibrous. So there is no opening. Fluid won't come out.
But in acute
That's,
catheter, it is there.
yeah, acute case, that's why you do supine position and lower volume, no? You can't fill 2 liters there. You can do lower volume and frequent exchanges there. Here it is not like, patient can't move. Here, patient can move. He can do his normal work.
Sir, 15 days gap we are giving in this. Alternate for the patient.
Sorry?
Like
He has to go do hemodialysis. If he is not planned early, so he has to go do hemodialysis till that time.
So this minicap, every time they are opening it, it has to be discarded.
Yes. Every time, nothing. See, bag also, you can't, again, once you disconnect, anything disconnects from here, no? It should not be reused. Everything has to be thrown.
So they can't just stop after filling and do their work and come back.
No.
They have
Drain, fill, then half an hour only it will take. Drain will take 20 minutes, fill will take 10 minutes. Then they can do the normal work. Because once you disconnect, no, you have to throw that bag. Again, you have to take a new bag again. Or else, there will be a drain bag available. Only one tube and one drain bag is available. If patient wants a break in between, they can take one drain bag, drain out, close it, then they can start. After that, they can fill also.
this is optional.
Optional. Because then no, there will be a cost involved there again. Again, they have to use one more drain bag. Extra.
Sir, what about the PD pouch? Is it disposable or
No, it is reusable. It's just like in a cotton or some material, in a cloth only it will come with elastic. They will tie here, then you'll keep it. Every day now, after taking bath, they can take a regular bath, no? PD patient can take a regular bath. Okay. Regular bath, no need to cover. No need to cover. Take a regular bath. Okay. Once they come out, they can change the pouch, then they can clean this with a clean gas piece. Okay. Then put another pouch and they can keep it. And they have to do that exercise, no? It will become wet. So there will be one bandage on that exercise. There will be no wound there. It will be a clear hole, clean hole like an umbilical. But still now, they should not leave water there for a longer time, moisture there. So we ask them to do one betadine dressing there. Just they'll do betadine, with a betadine they clean, then dry it, then close with a new gauze and put a plaster there. Okay, after bath. Okay, they can take a regular bath, no problem. And this also they can take. Once you close with a cap, no, nothing will go inside anything.
Hot water resistant.
Sorry?
Hot water resistant.
Hot water?
Resistant.
Yeah, no. How much hot water you take now? That hot it will withstand. Nothing to worry. We should not use boiling water and all. No?
This position will be supine only.
Sorry?
This position will be supine only.
No, sitting, supine, anything they can use. Sometime, no, if catheter is not in a position, that time, no, they might be sit for drain, complete drain. What happens, no, when catheter is towards lateral like this, little, when they sleep, no, till the fluid touches the catheter end tip, no, it drains out. Then it stops. Then if you make him sit, no, then fluid will accumulate, comes down. Then it drains out completely. If it is in a perfect place, then in any position it will drain out. Especially for APD, no, it should be in a correct position. Otherwise, supine position, sometimes it won't drain. Either they have to turn towards the catheter side or they have to sit for a complete drain. For those patients, no, we'll do tidal PD. Because some part of the liquid will be staying inside only. So that no, that alarm won't come. Unless no, 85% drains out from the water, 2 liters, out of 2 liters, 85% has to drain out. Then only it will go to next fill. Otherwise, it will give alarm, check patient line like that. Then once it comes 85%, then only it will go to fill again. Yeah. Otherwise, it will get overfilled, no? So peritoneal will be, interperitoneal pressure will become more because of more fluid inside for the patient. Yes.
Suppose patient, if it is not draining completely 80%, then how should patient stop the? He cannot open the inflow.
No, here manual, okay, we can do something. But in APD, if it is not drained out in the night, no, 85%, then we can't continue the therapy.
So he has to not, what he has to do immediately?
He has to sit, he has to change the position, then it drains out sometime. If at all, if it is not draining out, then you can't do APD for him.
That night he cannot do.
Not that night. Next night, it will happen same time. Same, no? Unless you have to, otherwise you have to reposition the catheter. You have to do surgery again. They have to reposition the catheter proper in position. Then he can continue. Otherwise, he has to go for manual. Sometimes, no, every day, he can't, in the sleep, no, he can't sit and last his sleep, no. He can't do that every day. If sometimes, no, patient sits, it comes out. But every day, night, he can't do that. So, this is not useful for the patient. So, they can go for APD, CAPD that time. Or in CAPD also is a problem, then he has to go for a repositioning.
Repositioning is possible.
Yeah, they open again, they'll same catheter, they'll pull it back there. Or laparoscopic they do, they'll pull it, take it there like that. So there are 3 types of catheter insertion. One is open, surgical is open, and laparoscopic and percutaneous. Percutaneous means they won't open more. They put a 18 gauge needle, okay, then they put a guide wire in that. Then there will be a peel away sheet with a catheter. So they peel away sheet on that, they'll put and take out the guide wire. Then they put a catheter through that peel away sheet. Then they'll peel and they'll insert the catheter. Yes, like that they do. That will be done by a nephrologist only. Interventional nephrologist will do that. Sorry?
Just like the POMA HD.
Yes, like that they'll do. So it won't, it's a simple but blind technique. We don't know where catheter is exactly. But we'll check the flow there itself. If flow is good, no, then we can do. There are doctors doing that also. Laparoscopic is the best procedure. We can see where catheter is going exactly. We can place the catheter in proper. Otherwise, surgical and percutaneous is the blind technique. So during the procedure only now,
After catheter insertion, we'll do flushing there itself. How it goes and comes out. Drain is good, we check it. Then only doctor will close.
We begin with our second session. I request Ms. Lakshmita Shetty, student of second year MSc Renal Dialysis Technology, to welcome and give an introduction about our resource persons of our second session, Ms. Veena NK and Ms. Megha Nagaraj Nayak.
Good afternoon, everyone. I would like to welcome today's resource person, Mrs. Veena NK, Assistant Professor, Selection Grade, Manipal College of Health Profession, Mahe Manipal. Welcome you, ma'am. And I would also welcome Mrs. Megha Nagaraj Nayak, Assistant Professor, Senior Scale, Manipal College of Health Professions, Mahe Manipal. Welcome you, ma'am. It gives me an immense pleasure to introduce and welcome today's resource person, Mrs. Veena NK, Assistant Professor, Selection Grade, Department of Renal Replacement Therapy and Dialysis Technology, Manipal College of Health Professions, Mahe Manipal. She has completed her Masters in Renal Replacement Therapy and Dialysis Technology, Manipal College of Health Professions, Mahe Manipal. Now she is pursuing her PhD at KMC Manipal. She is having 20 years of clinical and 10 years of teaching work experience. She has published 4 research papers in different research journals. She has also conducted various awareness programs. I welcome you, ma'am, for today's session. I would also like to introduce our second resource person, Mrs. Megha Nagaraj Nayak, Assistant Professor, Senior Scale, Department of Renal Replacement Therapy and Dialysis Technology, Manipal College of Health Professions, Mahe Manipal. She is a graduate with BSc in Botany, Zoology and Chemistry from MGM College, Mangaluru University, Udupi. Then she did her post-BSc diploma in dialysis technology at Manipal College of Health Professions, Mahe Manipal. After that, she worked as a dialysis therapist for 3 years at Kasturba Hospital, Manipal. During this period, she also handled the responsibilities of kidney transplant coordinator. She joined the MSc Renal Replacement Therapy and Dialysis Technology in 2011, the first batch at MCHP Manipal. Now she is pursuing her PhD at KMC Manipal. Since 2011, she has been working as a faculty at Manipal College of Health Professions, Manipal. She has handled various responsibilities in the department and at the institutional level. She has been involved in the curriculum preparation and development. She was a dialysis therapy technician, task force members in the dialysis therapy technology curriculum work by the Ministry of Health and Family Welfare, Allied Health Section. Currently, she teaches UG and PG students of renal replacement therapy and dialysis technology involved in guiding PG research work, IMS-related audit work, alumni relation responsibilities, interns in charge, patient education, and kidney awareness programs. I welcome you, ma'am. Over to you.
Namaste to everyone. Good afternoon. I'm Megha Nagaraj Nayak, and today I'm going to discuss a little bit about hemodialysis vascular access. And I'm from Manipal College of Health Professions, Manipal, Mahe University. So I think all of you know what is vascular access. And anyone? What is vascular? Any students? What is the meaning of vascular? Vessels. Yeah. It's there only on the board, right? Yeah. So what is the access? What is the meaning of access? Entry. Yes. So it is the entry to the blood vessel. Okay. So we are discussing very basic topic of the dialysis field. So I'm going to cover all these things today. So we'll just go through the history of vascular access. So when we see our vascular access history, so in the 1896, Jebulai and Briau, they found the artery end-to-end anastomosis, which is very important for the AV fistula creation. And Alexis Carrel, who discovered how to suture the blood vessels. Okay, and till now, that same technique is used for the suturing of the vascular access. And in 1924 to 1928, Professor George Haas performed first human hemodialysis, but it was not successful. And during that experiment, he used glass cannulae as a vascular access. And in 1945, Dr. William Johann Kolff, who is also called as father of artificial organs, he did the first successful hemodialysis, and he also used glass cannulae also, and he used venipuncture needles, what we use for other, like to remove the blood or to inject the drug, what we use, needles. Same needles he used for the dialysis also. And in 1949, Dr. Neil Alwal tried to connect artery and vein by the rubber tubes. Okay, and that is called as AV shunt. But as you know, rubber tubes are not that much biocompatible and not practical to use continuously. So in 1960, Dillard, Quinton and Scribner, first time they discovered AV Teflon shunt, and which was successful, and they connected radial artery and cephalic vein here. Now also we use radial artery and cephalic vein for the fistula creation. And 1961, Stanley Sheldon, he's from London, he said that first time he published that veins only can be used for the, as vascular access for the dialysis. Okay, so before that people were using like one artery and one vein for the dialysis. But he started using veno-venous catheters, and that was the temporary access. And 1962 to 66, James Simino, Michael Brassia and Kenneth Charles Appel, for that they got Nobel Prize also, and they first time created AV fistula. Okay, and this AV fistula, now also we are using the same technique for the vascular access creation. And 1972, AV grafts came into the field, and like that so many people worked in this field. Everyone's names we can't take here, and it will be like 1 hour class if I am going to take history of that. Yeah, and he is the first patient, chronic hemodialysis patient, Clyde Shields, and he was dialyzed by using AV shunt. For 11 years, he was undergoing dialysis. And this is the Carroll's suturing pattern, how anastomosis was done. And next one is Brasio-Simino fistula, that is radial artery and cephalic veins are joined together. So now we'll come to the topic, what is vascular access? So as I told you, vascular means it is blood vessel or any vessel which is carrying the body fluid. So here for the hemodialysis, we are using the blood channel or blood vessel. So access means entering to the blood vessel. So any extracorporeal circuit procedure you cannot do with the vascular access, right? Any extracorporeal circuit procedure means you have to get one vascular access, then only you can do that procedure. Otherwise, you cannot do that procedure. So for the hemodialysis also, vascular access is very important. And if vascular access is very good, it is functioning properly, then only you can adequately dialyze the patient. Otherwise, whatever you do, that is no use. Because if blood flow only 100, can you do proper dialysis to the patient? No. You can do the dialysis, but it is no use. It is like waste of all the resources also. So we'll come to the types now. So in the hemodialysis vascular access, there are 2 types. When we broadly classify them into 2 types, so those are temporary vascular access. So under that we can keep catheters, and another is permanent vascular access. So under temporary vascular access, we can categorize them into tunneled catheters and non-tunneled catheters. Vascular access under the permanent vascular access. So under permanent vascular access, we have 2 arteriovenous fistula and arteriovenous graft. So under the catheters, So we call them as central venous catheters, and what we use for the dialysis are the double lumen catheters. Double lumen catheters. These are the veno-venous catheters. So in the history, we have seen that though that time sometimes single lumen catheters were used. That is, one catheter is in artery, another catheter is in the vein. But now we use double lumen catheters, so that catheter is in the vein only. So that is the double lumen central venous catheter. So here we again classify them as short term or short duration central venous catheters. That is less than 2 to 3 weeks we are using them. And these are non-curved and rigid materials. And long-term or long-duration central venous catheters are used like 1 to 3 months or more than that. For example, perm cath. Maybe you are using 6 to 1 year, 6 months to 1 year, or more than 1 month, 1 year also. Okay, those are coming under long-duration central venous catheters, what we use for hemodialysis. And how we can keep these catheters for a longer duration? Because here cuffs are there. Those are diachron cuffs. Okay, so when you see the non-cuffed or short duration catheters, for example, femoral catheter or jugular catheter, subclavian catheters, those are not having any cuffs. So what we are using, perm cath, so what we are using for 6 months to 1 year or more than 1 year for long duration, those catheters are having cuffs. So what is the function of this cuff? These cuffs are like they avoid infections, and also they are helping to adhere the catheter firmly in that place. Okay, so that is the importance of cuff. So here in this diagram I have shown here, one is diachron cuff, that is cuffed catheter, another is non-cuffed catheter. Again in that non-curved catheters and curved catheters are there. Usually straight catheters we use for femoral vein catheterization, and curved catheters we use for jugular, internal jugular vein catheterization. And I hope all of you know, femoral catheters we are using for very short duration, like 5 to 7 days, maximum 7 days, not more than that, because infection chances are very high. And jugular catheters we can use up to 2 weeks. If a dialysis is for longer duration, or for example, maybe AV fistula, that creation is still pending that time, or maybe AV fistula is not working for a period of time, that time we can opt for the internal jugular vein catheters, which we can keep for longer duration. Again, that also not possible, we want more time, then we will go for the perm cath, that is cuffed catheters. And here you can see the locations where catheters are inserted. So very like long duration, means under the permanent catheters only, under the temporary catheters, that is short duration catheters, that is one is jugular catheters. Next one is subclavian, but nowadays subclavian catheters are not used in most of the centers because of the complications related to the stenosis. So next one is femoral catheter. If the dialysis or any extracorporeal procedures are for a very less duration, within 5 days or 7 days, we are going to stop that procedure, means we are opting for the femoral catheter. And another picture is related to the cuffed catheter. Also it is showing the where should be the catheter tip. Anyone know that? Where that catheter tip should rest in the blood vessel? Yeah, it's there in the picture. Right atrium. Okay. So I hope all of you know, whenever jugular catheterization is done, dialysis technologist cannot do dialysis without checking the X-ray. Femoral catheter means you can do without X-ray. Femoral catheterization done, immediately you can take that patient for the dialysis. But if it is a jugular catheterization, then without X-ray checking you cannot do the dialysis. Because if it is not in the right atrium, in that position, if it is like position is somewhere else, it is leading to cardiac arrhythmia or some other complications, major complications, which may be life-threatening to the patient. So always remember this, whenever jugular catheter, please check X-ray, make sure that position is proper, then only start the dialysis. So under the permanent vascular access, arteriovenous fistula and arteriovenous graft. Arteriovenous fistula is very common. Maybe all of you have seen these things. And arteriovenous grafts are also, nowadays it is used. Many patients are having nowadays. So these are some locations where arteriovenous graft and fistulas are created. So you can refer Handbook of Dialysis. I think all of you may be having that textbook. In that, this picture also there. So you can go through that once. Where are the locations of the catheters? Because I cannot explain all the sites of catheterization here, or AV fistula creation, or AV graft creation. That's why. So here, usually for the AV fistula or AV graft, it is always created for the chronic kidney disease patients, okay? And you know, chronic kidney disease patients means they will be on dialysis for lifelong. Otherwise, they have to go for the kidney transplantation. So now, like when the patient is CKD 1, 2, 3, 4, 5, like the stages are there, and that patient came to doctor, right, nephrologist, and now doctor will tell that patient, okay, after, like, if that kidney disease is very progressive in a fast manner, then they will tell, okay, within 6 months or 1 year, you may be going to the dialysis. Okay. So that time they will suggest that person that you have to go and take the appointment of vascular access surgeon for creating the vascular access. Okay. So what they have to do, these patients, what they have to take care. So first thing, preserve non-dominant arm for AVF or AVG. So usually what we tell, AV fistula or AV graft, in which hand it is there, they cannot use that arm for weightlifting or any hard work. So usually what we do, if a person is using right hand for everything, then fistula is created in the left hand. So non-dominant arm. And one more thing, non-dominant arm is kept and that is preserved. Preserved means that person cannot use that arm for blood drawing, means for blood test, again and again, blood test that person is going. So they cannot take the prick on that arm, okay? And they cannot use any injection, cannula, all those things, right? IV needles and all. Those things they cannot use in that arm. So AVF creation of anastomosis, AVF means, AVF is the anastomosis or joining of artery and vein. Joining of artery and vein, and it is not a machine and all. Some patients are thinking one small machine is kept under the skin. No, it is actually vein and artery joined together, and now what happened, artery, from blood from the artery is going to the vein. Okay, so vein is arterialized. Okay, so that is the AVF. It is a very small surgery. It may be under local anesthesia or general anesthesia also sometimes used, and surgery is done. Okay, maybe 1 day stay at hospital. And here for the hemodialysis, we are not going to cannulate artery here. We are cannulating only that vein only. Okay, but when we cannulate, we tell, okay, arterial needle, venous needle. But needle is inserted to vein, not to the artery. Because under the skin, already artery is connected to the vein, and vein is having that much flow now. Means per session, you want like 250 to 350 ml per minute blood outside of the body, right? For that, so vein is now having that much blood flow, which is coming from the artery. Okay, so you are going to cannulate only to the vein, not to the artery. So what is AVG? It is artery and vein joined with PTFE, that is polytetrafluoroethylene material, which is a foreign material, biocompatible material. For example, some patients may have some vascular problems like peripheral vascular disease or maybe diabetic. In them, you will not find very good veins. Okay, so you cannot cannulate that vein repeatedly. And you know, hemodialysis patients means per week 2 to 3 times they are coming. So you have to cannulate again and again those veins. So that time, here it is not possible to cannulate that vein again and again. That's why what they do, they use one tube, okay, polytetrafluoroethylene material cut tube, and that is joined to artery and vein. So where we are cannulating? We are cannulating to that tube. Okay, we are not cannulating to the vein. We are cannulating to that foreign material, biocompatible material. To that we are cannulating. But that will be under the skin only. It is not like shunt. Okay, so shunt was outside the body, but graft is inside the skin. So that is the AV graft. So here preferred orders, that is all of you have seen the AVF arm, right? So usually you will see in some patients, okay, they may be having like here, that is forearm, maybe in the wrist one scar, forearm another scar, brachial another scar, like that. That may be because of continuous failure of the fistula. Okay, so always in this order, preferred order is this one, that is first AVF fistula is created always in the forearm, then they will go to the next little upper to that. Next is arm AVG, that is AV graft. Then if all these things are failing or not possible, then only thigh AV graft. In the femoral region, AV graft. These are the orders of orders. Okay. So usually in the fistula, first snuff box fistula is there. Maybe you heard this. Snuff box fistula, it is in this portion. Okay. Next is wrist side, that is radiocephalic fistula, wrist area. Then it is little upper side forearm. Then another one is brachial fistula. Okay. So in this order fistula is going. In the beginning only, if brachial fistula is created, what is the problem? Problem is you cannot again go back to the forearm. Okay. So it is like in this order, if fistula is created, there are many options to create second or third fistula. So these are the locations what just I have listed now. Those are the locations shown in this picture. So these are the AV graft sites. So you can see here straight arm AV graft, another is looped forearm arteriovenous graft, another is straight upper arm and it is coming to the elbow side, and one more is looped arm arteriovenous graft which is near the axillary, okay, axilla. So here veins are not joined, but here artery and vein is joined to a tube, polytetrafluoroethylene tube, and we are going to cannulate to this graft. So when to create the vascular access? So temporary vascular access, you know that no maturation time. Okay. So immediately, today catheterization done, immediately you can call that patient for hemodialysis. It is emergency purpose also, we are using that temporary access only. And permanent vascular access, that is when we are doing permanent vascular access, we should plan that, okay, it should be little early. If we think that, okay, patient should not go for the central venous access, then in the well in advance it should be planned. As I said, at least 6 months to 1 year back only, patient will be called for the vascular access counseling, then patient is prepared for the vascular access surgery and surgery is done. And that time what is the benefit? Fistula will get enough time to mature. And I think all of you know, without maturation we cannot use the fistula for cannulation. Okay, so AVF at least 6 weeks required for maturation. Below that, if before that, if we cannulate the AV fistula, problem is AV fistula will fail. And AV fistula is the lifeline for the patient. Okay, so we cannot spoil like that. With before maturation only we are cannulating means we are spoiling the AV fistula. So AV graft, it is less than AV fistula maturation time, that is around 1 month is enough. So how to monitor and care the vascular access? Main thing in the both the things, that is hygiene, aseptic technique, standard precautions, all these things which we have to do in the hospital setup. Okay, and for catheter mainly if it is through the nasal carrier and all, infection chances are there. That's why it is always recommended who is handling the catheter and who is undergoing the procedure, both should wear the mask covering the nostrils. Okay, and for the AV fistula, we should take care that skin disinfection should be done, and needle site must be rotated continuously, not like area technique. It must be ladder technique or it must be buttonhole. So how to prevent the complications? Main thing is planning the vascular access creation at least 6 months before the hemodialysis, so that maturation time is there, and we can at least prevent the failure of the fistula. Then regular monitoring of the blood pressure, because in the beginning when fistula is created, that time if patient is continuously going to hypotension, means there is a high chance of fistula failure. So we should see that patient's blood pressure is not going very low, okay? And regular monitoring of hemoglobin. Maybe many of you have question, what is the problem if hemoglobin is going very high, 17, 18 and all? Problem is there. If it is going very high, HCT level will go high. So blood will become very thick, okay? So for normal person, no problem. For us, if HB is more, it is good. But for dialysis patients, if it is going more than 13, 14, then there is a chance that fistula is getting clotted. Okay, so that's why erythropoietin injection, that should be monitored, those dosage and all. Then must avoid area technique of cannulation, otherwise it is leading to aneurysm, pseudoaneurysm, all those problems, or skin infection. Then strictly follow the aseptic technique. Vascular access surveillance team must be there in all the hospital, who will monitor and take care of the vascular access, and who will educate and give awareness to the patient and caregivers. And one more very important thing, please document each and everything what you face the complication while handling the AV fistula or catheter or AV graft. Okay, so that other person will come to know next shift, or maybe next time any other staff is handling, they will come to know, okay, what is the problem. So only complications are listed here. So under catheters, very common complications are like hemothorax, pneumothorax, hematoma, bleeding from the site, air embolism, pericardial rupture, injury to the adjacent structures, like for example lungs and all may be punctured while catheterization, and that may lead to the hematoma, hemothorax or pneumothorax. Catheter thrombosis, it is later complication. Catheter, inside the catheter clots are formed, or fibrin sheath is formed. All these problems may come, and because of this blood flow is not coming properly. So central vein stenosis, if catheter is kept for longer duration. Infection, it is exit site infection, which is very okay because you can treat that with the ointment, okay? But if it is going inside, that is tunnel, or it may go to the CRBS side, that is catheter related bloodstream infection, then antibiotics are required, more vigorous treatment is required. Then catheter obstruction, it may be because of some other complications like catheter kinking, okay, or some damage to the catheter. All these problems may be there. So complications related to the AVF and AVG, non-maturation, decreased blood flow, thrombosis, stenosis means narrowing of the vein, swelling of the arm. Because of stenosis also there may be swelling of the arm, aneurysm or pseudoaneurysm because of wrong needle technique, Steele syndrome, maybe venous vein mapping, or before creating the fistula, if arm is not evaluated properly, that may lead to the Steele syndrome. Scarring and skin complications like infection or skin is peeling off in that area. Difficulty during cannulation, sometimes because of stenosis also we will feel very difficult to cannulate the vein. Post-HD bleeding, that is after termination of the hemodialysis, you cannot stop bleeding within 10 to 15 minutes. It is continuously bleeding, okay? That problem may be there. Recirculation, in some patients you will not find any vein to cannulate, so you will end up with cannulating single vein very nearby, no gap between artery and vein needles. So recirculation chances are there. Infection and cardiac complications, long time if fistula is working, or that maybe stenosis or higher flow in the blood, this fistula, all these may lead to the cardiac complications. So these are some pictures related to the complications. First one is aneurysm, Below that is the stenosis and thrombosis, which is they're treated by the use of plasty, angioplasty. Next one is graft infection. You can see the swelling, and another picture is related to the discoloration of the palm because of blood is not supplied properly to the palm. So what is the summary? Vascular access is the lifeline for the hemodialysis patient. Plan well in advance for the AVF and give enough time to AVF maturation. Take care of vascular access, which itself reduces most of the complications. As a dialysis therapist, make sure that all your patients are aware of how to take care of their vascular access and why it is important, because you should tell them, don't tie any thread to the arm, don't wear wrist watches or bangles. Sometimes ladies are making that tight. Those things, glass bangles, wearing glass bangles, or keeping the hand under the head and sleeping. All these things may sometimes making the fistula to fail. And one more thing, they always should practice. Maybe all of you know that physical examination of the AV fistula, right? Look, listen, feel, right? So they should check themselves. They are not depending on dialysis technologist or nephrologist or nurses. Okay, my fistula is working or not, you check. No, they should know. So what is your role? You should give the awareness to them. You should educate them how to check the fistula health. And you should handle their fistula like it is very precious, because it is the lifeline for our patients. Okay, so don't play with the fistula veins. So thank you. Any?
Good afternoon, everyone. Am I audible? Yeah. Am I visible? Because I am short. My student given me even stand here to I should be visible. Okay. So I am Veena NK from MCHP Mahe Manipal. The topic is given me to is the hemodialysis arteriovenous care and cannulation. First, I would like to tell thank you for the organizing committee giving this opportunity to give a small talk on this. So, I am doing the continuation of Megha Nagaraj Naik topic. She stopped there. It's a lifeline. Okay. So this is like Kantara to Mahabali. Sorry, what you were. So it is vascular access 2. Okay. So why it is given as a lifeline for hemodialysis? Because what is the uniqueness when you compare AVF with other vascular access? What uniqueness you are seeing in this? So it is physiological connection. Here, no foreign materials used. Patient own vessel is connected. Artery is connected to vein, so that vein is converted into artery. And it is autogenous tissue. That is, patient own tissue is used here. And more than that, it is palpable for thrill and audible for the bruit. It is B-O-R-U-I-T, but we call it bruit. Pronunciation is bruit. That is, we can feel the thrill and the sound, whether it is working or not. Okay? And it's the longevity. Compared to other vascular access, it is lifelong. It's a lifeline for as long as the hemodialysis patient is there. Maybe he will undergo dialysis for more than 10-15 years. If you handle the vascular access AV fistula in a good way, it will long last for more than 15 years. And compared to other vascular access, here complication is very less if you handle the vascular access properly. Okay? And so that you can reduce the healthcare cost. You know that once the problem is there with the vascular access, patient has to go admission and extra this medical fees he has to fill. So this, if you there are less complications, then you can reduce the hospital cost. And here blood flow, you will get the good flow. If the fistula is well matured, you can go up to 350 to 400 ml per minute. Usually the standard blood flow is 250 to 300 ml per minute. If you go for high flux dialysis, you need high amount of the blood flow, so you can achieve with the AV fistula. And the needles, that is attached only during the dialysis time. Then you can detach the needle. So that's why this AV fistula stands unique from other vascular access. So what are the components of AV? Now we have the vascular, we have AV fistula. How to care that? How to maintain that? So these are the components that will help the AV fistula care. First one is patient education. We have to educate the patient. That is, it is their lifeline and they have to care of them. The self-caring we have to motivate. Whatever changes they are feeling, they have to communicate to the healthcare staffs. Okay? Then access preservation. What Megha madam told is that, so not to, that hand is preserved for hemodialysis only, reserved for hemodialysis only, not for taking the blood samples, not for checking the BP. And he should be very careful that it is his lifeline. Okay? Then physical assessment. We'll learn that in the next slide. Physical assessment, he only do the physical assessment to see whether his AV fistula is working or not. Okay? Then we have the vascular access monitoring. I will tell the difference between the axial access monitoring and the surveillance. Okay? Then access pressure monitoring, that is pressure is checked within the vein during the dialysis. And few interventional procedures are required when complications are there. And patient empowerment. We have to motivate the patient to learn about regarding his AV fistula. So next, how to educate the patient? What are the components we have to tell? Okay, first we have to make him that importance of AVF. For CKD patient, once he is there in the third stage, we have to start giving the awareness about the AV fistula. Now guidelines are telling that better to start the dialysis with AVF only instead of catheter. What we'll do, we will wait till the fifth stage, then we'll tell the patient you need the dialysis. That time vascular access is not there. Then we'll go for the catheter. So if he is there in the third stage and we know that his disease is progressing, maybe in future he needs dialysis, that time only we have to give the awareness that you should have the AV fistula ready. When he needs emergency dialysis, we can start the dialysis immediately with the AVF. So we have to introduce him about it's a lifeline for the hemodialysis patients. Okay. Then little bit we have to give the awareness about the anatomy and physiology so that it will make more interesting for them. And we have to give the awareness about the care and how to maintain the AVF fistula. And self-monitoring and observation also, we have to tell them by giving the few pictures, showing the pictures or videos, we can teach them. And we have to motivate them to have the good nutrition status and to more be good with the hydration also. And medical management that the staff should do as per the requirement. And we can advise them for the lifestyle modification, to have the exercise, to quit the alcohol, to take the regular exercise. These things we can teach them. And communication advocacy. The patient, sometimes maybe they feel some abnormality in their hand, but they hesitate to share with the staff. We have to motivate them, whatever it may be. If you feel that any changes, you can come and you can share the problem with us, then we can evaluate that whether it is any further in this one procedure is required or not. Then follow-up and support. We have to give the regular follow-up period for the patients, and thereby we can give the support to the patient. And physical assessment of the AV. This is very, very important. Physical this one assessment. Mainly we are using the 3 tools: eyes, ears, and fingertips. Okay. So eyes, we have to, before starting the dialysis, we have to do the physical assessment. That is, with the eyes, we have to do the inspection, whether any infection is there, any change, a color change is there, any abnormality is there, any bleeding is there, any oozing is there, tenderness is there. This thing, that is, tell that some abnormality is there in the AVF, whether we can start the dialysis or not, whether we have to inform to the physician or not. Okay, then we have to feel with the finger, we can feel the thrill. It should be continuous and vibrating thrill, that feelings you feel in the hand, that should be continuous and soft. If it is hard and a little bit this one, then something abnormality is there in the fistula. Finally, that is Bruvi. Listening the Bruvi with the stethoscope, you have to ask at the Bruvi, so that you can get where is the artery, where you have to give the needle prick, venous needle spot, where to choose. These ideas you will get. And finally, documentation is very important. Whatever you do in your field, finally the question comes research, whether you have done any research. Okay, so now only in the student life only you do your practice, that documentation, that is nothing but indirect data collection. Maybe you are helping your seniors, your PhD scholars, that when they come, when they do the data collection, whatever information you have documented, you do the correct document so that they will get some clear documents. Maybe in the future, when you do PhD, it will help you for also. So do the practice of whatever work you do the documentation. So look, listen and feel. Okay, this is not too clear. I taken this from the handbook of this one, comprehensive curriculum for dialysis technologists. So what you have to see is any swelling is there in the hand, any redness is there, pain is there, okay, any bluishness is there. So these things you can look by, see the any abnormality in the hand. Feeling that pulse, that should be very soft pulse, you can stop by pressuring the down on it until it is constant. It should be constant. And skin temperature, it should be normal. If it is hot, means it is inflammation maybe is there in the hand. Okay, and listening, breathe should be low pitched and it should be constant. So these, any abnormality in these things, then you can make out that some problem is there in the fistula. And maybe you heard about 6 rules. Have you aware of this 6 rules, AVF? So by doing the physical assessment, you will come to know that whether the vein is suitable for cannulation or not. Sometimes from the OPD side, nephrology doctor, they will send this patient for hemodialysis. You start the dialysis. As a dialysis technologist, it is our responsibility. We have to check whether we can start the dialysis with that particular AV fistula, whether it is matured or not, okay, whether it is suitable or not. Okay, any changes is there, then we can give the report to nephrologist. Because of this reason, we can't do the dialysis. Actually, once the fistula is matured, it should meet, that is, that blood flow should be 600 ml per minute, and the your vein should be 600 mm in diameter, and it should be 6 mm deep. And whether if you have the straight segment, it is good for cannulating. And that maturation period is recommended is 3 months. Okay. Then importance of doing the AVF physical assessment. What is the important? Why we have to do? By doing that, we can do the early detection of the complications. We can optimize the hemodialysis treatment, and we can prevent the access dysfunction, enhance the patient safety, improve clinical outcomes, and we can cost saving also we can achieve. So the aim of assessing is to check whether AVF is matured and ready for initiation of the cannulation. Vein looks, it should be look mature enough. Vein feels prominent, straight, and it has a strong thrill and good groovy. Then you can go ahead with for the cannulation. So I told you what is the difference between monitoring and surveillance. Okay, you maybe hear this two terminology together, AVF monitoring, AVF surveillance. So what is the difference in? So the primary goal of this monitoring is just to ensure the immediate safety and the functionality of the AVF during the dialysis session, allowing for prompt intervention if any issue arises. Okay, and it aims to ongoing observation, assessment during the dialysis treatment or clinical visits. It involves regular checking the access site for signs of function and complications and abnormalities. Whereas surveillance, the primary goal of the surveillance is to proactively it is address the potential issues before they compromise access function or leading to complications. It aims to optimize the access performance, minimize the need of interventions, and prolong lifespan of the vascular access. Involves a more comprehensive and systematic approach to monitoring the long-term function and state integrity of the AVF outside the dialysis treatment. Okay, this surveillance is for the long-term planning, whereas monitoring it is online. When patient come for the dialysis, that is we are doing. So again, what are the components of monitoring is, components involved in AVF monitoring is physical assessment, blood flow monitoring, access pressure monitoring, intradialytic monitoring, and regular surveillance imaging, patient education and self-monitoring, documentation and communication. This documentation and communication, every time in every slide I will tell, so here onwards you have to do the documentation. Because I am giving the info, because I am the PhD students, when we get the data, it is very clearly, then we are very happy. So that it is the documentation will be done by many people. So if you join the hand, then it will be helpful for the future research. Okay, then components of AVF surveillance, clinical assessment, vascular access flow monitoring, access pressure monitoring, surveillance imaging, and patient education self-monitoring, again documentation and communication. Okay, the summary of this monitoring versus AVF surveillance is that while both monitoring and surveillance involve assessing the hemodialysis vascular access for function and complications, monitoring focuses on immediate safety and functionality during the dialysis treatment, whereas surveillance takes a broader proactive approach to long-term access management and optimization. Okay, so now what are the general protocol steps for cannulating a fistula? When we cannulate the fistula, we have to follow the protocols. This may be changes from centers to center. Few guidelines will be common, but few centers will change minor. That suggestion, this one points that they will change. Okay. So first of all, we have to do the preparation. Both patient and the person who is going to cannulate, both they should need the preparation, because the person who is going to prick, he is also get nervous. Suppose he is a new staff, he should stabilize himself. When you go for cannulating, if you vibrate your hand, then patient will also start, according to your rhythm, he will also vibrate. So you should be strong. By seeing you, you should get the confidence that this person is well trained. He is going to cannulate me. Okay. So if the patient is new, he may be worried about how the pricking will be. So make him prepared for that. Okay. And do the before doing the cannulation, I told you make the practice every time. When you touch the AV fistula, you do the physical assessment. Okay. Do the patient assessment. Then you then you select the needle. Select needle means needles. AV fistula comes in different gauge. You know the gauges. If gauge number is more, AV fistula is big or small. Suppose if I take 17 gauge needle and 15 gauge needle, which is bigger in size? 15 is bigger. So as the gauge is lesser in number, your needle of fistula needle size is more. For whom you are using this one? If I give two choice, 17 gauge and 15 gauge needle, how you choose the patient? One is regular patient, one is first fistula patient. Which needle you use to which patient? First fistula patient, 15 gauge. Which one? 17. Because first time is going to get the prick and maybe his vein is not stabilized. So you have to go with the small size needle. If regular patient, you can go for the higher by seeing his history, whether blood flow is good or not. Okay. And preparation of the AVF site. Now you selected the needle, because whether you know that if he is a regular patient, he is a first fistula case, like that. Okay. Then you have to prepare for the AVF site. You have to choose the 2 points, that is to take the arterial blood and to return the purified blood. Then you have to go, you are going to cannulate. Okay. Once you cannulate, make confirmation that whether you have cannulated it properly or not. Then keep the needle in the position. Then after that, my work is finished. No. After cannulation, you will start the dialysis. Then you have to monitor in that 4 hours whether the patient is moving his hand, whether any changes is there, whether your venous pressure is not stable, it is not stable, it is increasing. These are the signs, and this one hint that is giving that something is going wrong with the fistula, that you have to monitor the hand. Then after the dialysis, post cannulation care also there that you have to do. Again, in every step, pre-cannulation, during the dialysis, after the dialysis, you have to educate the patient. Okay. Then you have to follow the post-procedure assessment, then finally monitoring and follow. Okay. Then before cannulating the patient, you should have the physician's order. He should give the order. You have to start the dialysis with the AVF. Okay, then your role starts. Okay, so usually experienced, qualified staff will go for the cannulation. That's why we are telling during your training period, you get the exposure to have the cannulation. So when you come to the internship, you will become stabilized and you are able to do the cannulation. Most of the time, have you seen when you work in the dialysis center, usually the nurses, they work in another station, they will also come, they will join to give the dialysis treatment. They tell that we are familiar, but pricking is nothing for us, we'll prick. How many blood samples I have taken, you know, this usual dialogue will come. But AV fistula is not, it is not ordinary vein. It is lifeline of the hemodialysis patient. It is for him lifelong term. Okay? And what they do, they for the blood sampling, once they will prick, then they will take that sample. Then when that patient will come after 1 year or 6 months, right? But this patient, he will come every alternate days. Again, we have to use that particular hand. Again, same vein will be used. And once you prick the needle, it will be there for 4 hours. Okay, that is the difference between the ordinary blood sampling and this one. Even they have the experience taking the blood, they should train properly before they handle the AVF fistula. This should be convinced them. Okay, this is the lifeline of the patient, so that it's our responsibility to tell this clearly. Okay, then for the new patient or regular patient also, you can use that to make the vein prominent. Another assistant, they can hold the hand, or you can use the tourniquet to make the fistula vein more prominent. Okay, then usually the needle insertion, which angle we have to prick. If the needle vein is superficial, you can go to 15 to 30 degree this one, and if it is little bit deeper, you can go to 30 to 45 degree angle. Okay, now controversy is there whether I have to use dry this one fistula needle or wet. I prefer wet fistula needle, because if any counter puncture, something, any small this one, what your counter this one is pricking happens, means we can adjust with the saline. If you use the dry needle, there is nothing to check, because air will be there in the column. You can't push also, you can't suck also. You have to remove the needle. So that's why, and sometimes maybe Megha told clotting chance is more. So if you use the dry fistula, chance of clotting will be there. You should be that much experienced person to do the dry wet needle. So next comes, you have to ask the patient, wash your hand. Madam, chanda snana madi bandidene. Nanna kai athara brush alli tikki bandidene. No need. No, he will travel from the home. So maybe dirt will be there. Convince him, maybe sir, but still you are traveling. You wash your hand, better to your infection, this one only. Okay, so ask the patient to clean the hand, and most of the time the staph aureus will be the causing agent for the infection. Okay, then you do that, look, feel, and choose the straight segment for AVF cannulation. Okay, the segment must be a long as a needle length. Stay at least 1.5 inches from the centimeter from the AVF anastomosis. When you prick the arterial needle, it should be faced towards the anastomosis, but you have to keep the distance 1.5 to 2 centimeters. Okay, and your venous should be away from the arterial needle, and you keep the distance, more distance from the arterial needle. Why this is, if I put in the same direction, dialysis will not happen? Dialysis will happen. Then why I am stressing this one? You put artery and the venous needle in the opposite direction. Why? What is the importance? Yes? Recirculation. It is access recirculation. In case of AVF, 100% access recirculation is not happening. In case of catheter, there is whatever circus you do, access recirculation is there. But AVF, we have the chance, we can avoid the recirculation. Okay? And so, when you face this pricking the vein, some vein will be a little bit slippery, some will be prominent. Okay, that is why you have to use the 3-point technique. You hold in the left hand, you hold the vein, and in the another hand, you have to prick the vein. Okay, so before pricking the vein, how you have to clean the sides. When you choose 2 sides, you go for circular motion. Once you start from the point, then go towards the periphery, so that you will not get the pricking point. So make that, thereby you can avoid the infection. Okay, and commonly used this one antiseptic lotions will be 2% chlorhexidine and 70% isopropyl alcohol. Okay, so now we have what are the types of needling technique. Okay, you have buttonhole technique, area puncture technique, rope ladder technique, button cannulation technique, cannulation with guide wire technique, ultrasound guided technique, and back tip needle insertion. First 3 is very familiar. Okay, in that hero is buttonhole technique. All are appreciating it. Infections are there, but I have not tried that. I like rope ladder technique. Okay, so I will explain in the next this one. Area technique that will cause the aneurysm. Okay, and other 4 are not that much in practice. Button cannulation technique, they use one device. They will place one device. So in that only you have to, no challenges for you. You will not get that much happy. But cannulating in this one different way that you, today I pricked within this one, that happiness will be there within you. Okay, and guide wire technique that will be used for challenging patient. If vein is not that much prominent, you can go with the guide wire. And ultrasound guided also, by using this one, leaving the vein, you will cannulate that. And back tip needle, this one, that is bubble down cannulation. Okay, and this is the buttonhole technique. This technique involves the repeated puncture of the same site at the same angle into the same hole each dialysis. Sometimes patient will ask, same person should come. That is not that. Buttonhole technique, same site, same angle, same distance. That person is, call him. He will add to something to the buttonhole technique. Okay. In this technique, aneurysm is less. So area puncture technique, this is very favorite technique for the patients, because now every time you are not pricking one point, you are pricking the area. What will happen after having many prick? You will not, that pain sensation will be not there. In our childhood, when teacher, he used to pinch in the thigh region or the same pinch, nothing will happen. So patients are very happy with they will tell area technique. But area technique is causes aneurysm. Okay. And rope ladder technique, this one I am very happy with that. In that my mind is I am saving their hand, but every time they have the pain, more pain will be there, because every time you are pricking the new area. Another this one side effect of this, you are damaging whole vein. That is one of the back this one, but if it is heals properly, then it is better. And steps for removing the AV needle. What is that? Just pull the needle and you press. No. AV fistula, I told, it is for the repeated entry. Okay. So take care of when you remove the needle, how will remove? Blood should not bleed. So you will put the pressure on this one, then you will pull the needle. So patient will have the pain, again you will do the counter punching. So you should be skilled person that when the tip of the needle comes, simultaneously you have to put the pressure on the site. Okay, and where you have to pressure, you have to cover that full area with your thumb. You may think that I'll give more pressure, you will put like this. No, this pressure is not enough. You have to give the thumb, one finger pressure you have to give. Okay, and you have to cover that particular area, because when you prick the vein, first you are going through the skin, then you are entering into the vein. So that when you cover the skin, what will happen? Maybe inside the vein, that vein may not be closed. So internal bleeding will happen. So you have to close full that skin and the vein. So how long you have to hold? Just then you are saying, no, this should not happen. At least 5 minutes you have to give a good pressure. Then it will stop. Okay. Then again, for removing the needle, you need the preparation. After the removing the needle, you can't give it. Usually post dialysis, sometimes you may require to give the antibiotics. Once you remove the needle, you can't give it. Again, you have to prick. Then the patient will scold you. So do all the arrangements. What are the things you have to do before removing the needle? Okay. Then after removing the needle, do the assessment whether you have removed the needle properly or not. Okay. Let it stabilize. Then you put the direct pressure on the side. Okay. Then do the documentation for any changes. Then stop bleeding from the dialysis fistula needles. How to stop? Apply the direct pressure. Sometimes it is not effective. Then ask the patient to lift his hand above the heart so that the supply to that hand may be stopped. You can stop the bleeding. You can use the ice pack also. You can use the hemostatic agents, and you can use the pressure applying this one equipment like tourniquet also you can use. But you have to tell the patient that after going home, you have to loosen it. Okay? Otherwise, patient will keep the tourniquet till morning. By that time, your AVF will be, Okay? So, monitor for the complications, and if any emergency is there, you call the medical team. Okay? Complications during the AVF cannulation. What are the complications you may face during the cannulation? Infiltration. This is very familiar. Okay? Once you become skilled, this will be reduced, but in the beginning, this experience will be there, infiltration. And hematoma, if infiltration is there, then this hematoma will be automatically, it will come. Okay, thrombosis is there, stenosis is there, infection. Then artery puncture is very rare. Pain will be there, fistula aneurysm will be there, psychological distress. Patient may be, first time he may not be knowing what is the pain then. Next time he will not come for dialysis. Maybe he will have the psychological stress. Then if you are not handled properly, the chances that access loss will be there. That is very dangerous. So how to prevent infection during the AVF? So you have to do the hand hygiene. You wash your hand with the saline before you start the case. Then follow the aseptic techniques, and you should be careful about the needle site care, skin care, antibiotic prophylaxis also you can use, and environment control that you have to do, and finally patient education. Maintaining or improving the dialysis fistula patency. That is regular surveillance and monitoring you have to do, optimizing the dialysis parameters, hemodynamic optimization, what Megha told. If patient BP drops during the dialysis, the blood supply to the fistula will be less, then it will indirectly it will affect the fistula. Lifestyle modification you can advise, and interventional procedures, if anything is required, then you can refer to the surgeons. Again, here the patient education and empowerment is important. Then preventing AVF failure, optimizing vascular health, monitor and manage the blood pressure, promote the adequate dialysis. Patient should go adequate dialysis. What do you mean by adequate? What do you mean by adequate? Whether patient dialyzed enoughly or not, because he is coming alternate days. Our kidney, it will work for 24 hours. Whatever waste is come, continuously it is going to drain. But in case of hemodialysis patient, one day it will be filled, next day we are draining. So that much time you have to cover. So patient should undergo enoughly dialyzed. Adequately means effectively dialyzed. Okay. And encourage the patient to have the medication adherence. Okay. And ask them to practice the aseptic technique, and you have to do the surveillance monitoring, patient education empowerment, and intervention and treatment if required. Final key message is that hemodialysis arterial fistula is a critical component for renal replacement therapy for patients with end-stage renal disease, providing reliable and long-lasting vascular access for hemodialysis treatment. Proper care and monitoring are essential to maintain the function and integrity of the AVF for minimizing the complications. So, save the lifeline of hemodialysis patients. Thank you.
Students come as a group wise. As we came for first session, we came same like that. Two groups. Ma'am will explain demonstration of AVF cannulation.
Look for any infection, any abnormality that you have seen. Then next you have to choose two sides. Or that is artery, that is to take the impure blood, and vein to enter the vein. Here I feel we can avoid the access disadvantage. Right? So this strong also it is not moving. This slippery veins, slippery veins is there. Okay? When you try to pick this vein, what will happen? With the one hand along with the needle, if you go, it will move like this. So even needle will be not there in the inside the vein. Okay, it will counterpuncture the bulging matter. For this type of vein, what you have to do, you have to I will ask the question you. I will take the artery 2 centimeters. I will just think that anastomosis here. I will take the artery like this. I will prick towards the anastomosis, but I will keep 2 centimeters away from the fistula. I will take this one as the vein. Are you agree with this? Why? See the hand. See the hand. I told artery I will take like this. Okay, I will keep 2 centimeters away. That's the rules I will follow. I will take this vein. Where is circulation? Where is the? I am taking another segment now. You are right. See here it is loop. Here it is loop. Whatever you take from the blood, you return. It will recirculate here only. That you have to see properly. Okay, recirculations you have to avoid. So I have pricked the artery here. Vein somewhere here. Somewhere here I will choose. That is away from the fistula and access recirculation will not be there. Okay, and you choose the straight segment. Okay, instead of using here. Suppose your needle length is up to here. It will come this point. Here little bit diversion is there. So there may be your tip of the needle will touch the wall. Maybe it is there in the vein, but it is touching the wall. It is not exactly in the inside the vein. So when it is touches the vein, so there will be resistance. Okay. So if resistance is there, what will happen? Returning blood is not going freely into the body. So resistance is there. What will happen to the circuit? High venous pressure. High venous pressure that will cause the clotting. Slowly the circuit will clot. Okay. So that you have to choose the segment straight, and I will avoid this point also. Why? What may be the reason? It is straight. I will go through this. I will put a needle, but I want to avoid this side. Why? Folding. Maybe during the dialysis, you can't sit for 4 hours to see like this. Okay, patient by chance he may move the chance that the counterpuncture may occur. Okay, so better way for this hand, artery will be this, needle will be this. So first you gather the things, everything ready. Okay, once you are going for cannulation, then don't go for searching the where is the needle, where is the swab. No, keep everything ready. Then choose the sides. Then now you have to clean the site. Okay, down how you have to go. This point is there and this point is there. Suppose this point is there. Start from the center, go towards the periphery, like this. Okay, then you discard that. Again, second one you take. Again, after going here, again you don't come like this. Okay, few people will practice like this. It is easy. Don't do that. You go. This is the good practice to do like this. Okay, again for this point also. Suppose if you chosen 2 points here because you don't have the vein here, then what you have to do? You have to start from here. You stop it here only, and give this chance to this one and go for here. Okay, so protect that point for the pricking. So there you can avoid the infection. Okay, then prominent superficial, that angle will be changed 15 to 30. If it is deeper, 30 to 40. Understood, no?
one more thing. Whenever you prick the veins, that all of you are following, right? Aseptic technique or universal precaution. So first step starts from where? Hand wash. Yeah. Just think that I already washed my hands. Okay. No bangles or watch in my hand. Okay. So all those things are important. Then mask. Yeah. So mask
you have to
should
cover
wear.
full
Mask
one
you
nose
have to
and
cover
mouth.
the
Few people
nostrils also.
will close only this much. No.
Yeah. So it is not like just you are covering your mouth. So it is, if it is catheter, you must close your nostrils properly. Okay. Because of that also sometimes catheter exits at infection chances are there.
And better you have the goggles also. If fistula is very good fistula, when you put the pressure, once you prick, you have. Can I open the needle? Jayan, needle open ಮಾಡ್ಬೋದಾ?
Just see how ma'am is opening the needle.
I will not wear the glove. Is it okay? Just to demonstrate.
Beda. So this is now sterile pack, correct?
So just I will make them. Yeah. Can you see one eye opening
One
here? That
hole.
is called back eye. That is called back eye. Because usually this is called bevel. Usually you prick like this. If no opening is here, it will be closed. So flow will be coming only on the topper side. If you have opening here also, you will get the good flow. So usually it is preferred for arterial, because arterial is to take the blood. Vein, it is not an issue. No need to have the back eye. But back eye is very important for the arterio needle. Okay. And usually there will be one dot here. So whether you have, after pricking, you don't know whether you have pricked bubble down or bubble up. So usually dot will be there to identify that in this needle it is not there. Okay. So once it pricked, you have to tape it properly. Okay.
So just consider that this is the sterile pack now. Okay. So how to open the pack, all those things you have practiced? Yes. So just one needle is already removed. Just I'll keep that in that. So whenever you open the pack, make sure that you are not touching inside it. So hands are washed, clean. Okay. So it should not fall down. Now this tray is little small. Okay.
So anyhow you have the dressing pack with the cover. You spread it throughout the
properly you
stand, so that if it is out of the tray also, it will be there in the sterile area only.
So done. So what all things you want, everything you should keep in that sterile pack, and make sure that nothing is falling down. And if it falls down, don't use that. Okay. Yeah. So how to wear gloves? Huh. First left hand. Okay. Any hand, it's okay, but make sure that, any hand, it's okay, but make sure that which is the sterile part and which is the unsterile part, you know. See, once you are opened it, actually you should not touch this part with your hands, because it becomes unsterile that time. This part is okay. You open, you just touch this part. Now, understood? Now, after washing your hand also, you feel that it is not sterile like that, right? Just cleaned. Your hands are cleaned, not sterile, right? So, now I am touching only here.
Because later it will go to touch your skin.
So, I am not touching that side, which is actually I am touching the patient skin, right? Yeah, done, right? See how I am holding now? So, I am not touching this gloved hand to this unsterile part. Now, I am just inserting these fingers here properly. One more thing, make sure no jewelries or watch, ring, nothing is there. Okay. So, only sterile part is touched, not unsterile part.
Once you wear the glove, make it like this. It will be fit to your hand.
So, I am not touching back outside also.
Once you pick that, when you start picking that mid time, you will feel that glove is not wear properly. So, once you wear the glove, do like this, fit it to your finger, then you start cannulation.
So, I took 4 gauze pieces now. So one more thing, make sure that person who is assisting you, when they are pouring the spirit or method in anything, you are not touching their hand or that bottle nozzle or anything, or your surrounding. See, sometimes your body language also very important when you are doing the sterile procedure. Maybe you have seen when the doctor is coming and doing the catheterization, after cleaning the, washing the hands, how they come? They'll walk like this and come, like ramp walk. No, how? Like this or like this they'll come. Why? They are not supposed to touch. That they know. They will not touch. And they will make sure that others also will see that. And you feel that time, okay, this person is coming like this, means I should not go and just touch that person's hand or going and shake hand, all those things, right? So that is also very important, okay? Yeah. So actually when we use when patient is there, then what we ask them, just raise your arm, all those things. So some people don't clean back side of the arm, as ma'am said. When the patient comes to the dialysis unit, make sure that patient washed their arm properly. Okay, they may be telling I wore a full sleeve shirt, all those things. It's okay. Ask them to wash the hand properly. Then actually folding the arm, or maybe from here only fistula is there. So you are cleaning that back side of the arm. Understood? No? Means you are not touching the patient's hand that time. Patient only folding the hand. So that time you are cleaning this portion.
Not only the sides you have to clean, you clean whole hand. Maybe that day you are cleaning with the sterile patient, usually they have the itching sensation. Okay, after that going home they will scratch. That also sometimes you can avoid because they are scared to touch the fistula hand. So you clean full hand. Okay, then you keep that area in the sterile area.
Here it came. What is this here? Okay, so you should know waste management procedure also. And sterile cloth, when it is there in the dressing pack, that cloth you can keep below the arm. See here, I only lifted the arm. So patient's arm, you are not going and lifting the arm, then your blouse will become unsterile. Okay, you just ask patient to lift the arm. Okay, so done. That I have just discarded it. Give one more. Now, one more thing. Spirit gauze pieces also. Like arterial side you cleaned, then venous side also you are cleaning with that. No need. You have enough cotton gauze pieces, right? So make sure that, now for example, if this one I am taking as artery, okay. So puncturing side, then periphery. Understood? Don't do the conjusi to clean the arm. Okay. Only that point. Done. No.
If it is too near, two sides are very near in same segment, then I told don't go towards the another side.
Another side.
If it is distance, you try to clean it
as much as
possible.
Okay. So I am taking the same gauze. Actually, don't take. You just throw that. Then another gauze. For example, if here I am not going to cannulate because this is elbow, right? If no other option, you will cannulate there only. Here I feel okay, very good vein is there. So if I am going to prick here, so again that side. Always try to clean with the artery forceps only. Practice it. Usually what people are doing, with the bare hand it is easy to clean. Okay. So you will go just wipe it with like how you mop the floor, like that. Okay, not like that. So then it is bedded in some hospitals they may be using AHD solution or some other solutions according to their protocol. So you have to see the protocol first wherever you are going and working later. So first see the protocol, which all disinfectants they are using, how to use those disinfectants.
How long you have to
according
keep?
to
Suppose
that.
if you use the spirit, the timings they will give, either it is 1 second, 2 second like that. Next you have to use the another solution. So what protocol is there? That should be familiar with you. Then you follow the same protocol. And make sure that by that time when you clean that arterial, this equipment that should not touch the patient body. Maybe
Patient's body.
sometimes it is your AV fistula with superficial need vein, maybe it will be, you will get hurt. Okay, so make sure that this one cotton.
Cotton is
this,
more.
that
And you are
ball is
cleaning
very
it
good.
properly. Okay. So now I cleaned with spirit and betadine. One more thing, some patients may have betadine allergy. Okay, many patients are there. So that time what we will do, usually we skip the betadine or we just allow it for dry because betadine is effective after it dries, right? So once it dries, immediately we clean that with the spirit. Okay.
So this you will get by the documentation. What I tell, so maybe this day she may be handled. She come to know that he is having allergy. If she noted down, next shift tomorrow maybe you are handling, you are not knowing. You can see the history. So that is the importance of that documentation.
So make sure that whether patient is taking any local anesthesia needle before cannulation, or spirit allergy is there, betadine allergy is there, or AHD solution allergy is there, all those things. And if any discoloration is there in the skin, just ask the patient, itching is there, all those things. First, what ma'am said, first you will inspect, right, those things. Okay, now for example, you will see here, some scarring is there, some problem is there. Try to avoid that area. Okay, usually most of the patients are loving that area technique. Again and again, same place you prick and it becomes white after a few days. Okay, so that time try to avoid that and make sure that you are cannulating little away from it. Okay. So now disinfection over, skin disinfection over. Now, so dry stick needle also some people are using. I am actually comfortable with wet needles.
Maybe fistula that I will need this one. If this prick the and yeah.
And just give me that syringe.
Prick the See, when you prick that, no, you should not touch the tip. So now you have transmitting the infection. Okay? So immediately once you remove, directly you have to prick. So that's why you are telling follow the AHSCON technique. Now again when you open that, you don't touch the tip. Okay?
And all of you know, right, you cannot recap the needle. All those things are infection control protocol. Okay.
Just press it, ma'am. Press. Again you just recap that, okay? Yeah, pinch it there. Pinch and replace the cap.
This is very loose, this syringe. Actually, usually we use around 20 cc like that. And so I flushed or primed the needle with normal saline. Okay.
Another benefit of having a wet needle, no? If patient is very sensitive, that sterilant will go to patient body. So you are rinsing with the normal saline. How you are priming the blood tubing? That's why I prefer wet needle only.
One more thing, in protocols or some guidelines, they are not telling properly whether it is bevel up or bevel down. According to that person's clinical experience and all, sometimes that is what is comfortable to them. Like that, most of the people will cannulate. Okay, so I am cannulating bevel down here because it is having back eye, so no need to worry about how blood is coming and all. So blood will come. Okay, and see here now, vein here. This vein is firm. Okay, but if it is actual vein, how ma'am showed in her arm now. So if it is slippery, when you prick, that time vein is straight. When you just entered inside, it is slipping. So that time better you ask, or sometimes patient is new to the dialysis. Okay, patient is scared of needle prick. That time better someone you ask and ask them to hold the arm. Okay, usually means that person who is assisting, that person will not touch the fistula, that puncturing side. Okay, so little away from it and make sure that they will press properly, locate it.
So I'll just demonstrate,
Okay.
just to show you one hand. Okay?
Yeah.
See, vein is not visible now. Ask the patient to do like this,
Clench the
cluster. Okay. So then you have to, you have to hold here, then push. Okay, see, now it has become prominent. Just feel here, you can feel the vein.
You can see, earlier it was not there.
Right? Earlier it was not there. See. See.
Now it is not there.
Now
then
it is not there. So just you pinch your hand and this one. See, now it is prominent. It's visible also, and you can feel also.
Feel also.
Okay, like that,
is
you have
one
to do
thing.
the.
Or while cannulating only, if you are very confident that vein you will not miss and all, don't touch the puncture side. Just pull the skin little bit back, and with another finger you can just make sure. Don't press. Okay. If you press, what is the problem? When you go inside, and that time there may be bulging chance. That time. Okay. So here, and one more thing, not directly to the vein, just first to the skin. Here I cannot show those things. First to the skin, then to the vein.
So that's why I told while you apply bleeding, to stop the bleeding, skin opening will be little bit forward and opening of the vein will be little backward. So you hold that area you have to press. Okay.
Automatically it is coming with the back only. When you go to the vein, immediate air will not come. Here little bit air came. Air will not come. Like this backflash of the blood you can see. It means you are properly in the vein. But don't waste time like this. That just you check the flow and see that it is going inside properly. You can feel here also that flow. Whether flow is proper or not. Okay. And if it is vein, so it's okay that if it is going properly inside, no bulging, patient is not complaining of any pain, then it's okay. Now, one more thing, after cannulation, some people are having the habit of flipping the needle.
Turning the needle.
Turning.
Don't turn the needle.
Okay. You should not turn the needle. Just keep like that only. Like if you want to prick, bubble up, okay, you prick, bubble up only. Don't flip later. Or bubble down only you cannulate.
Decide in the beginning only. And one more thing, what we told, first you go to the skin, then to the vein. Because not that skin will tightly seal on the needle. If you go directly to the vein, that will make an opening there. If opening is there, infection chance is more. And oozing, slight oozing will be there. If well developed fistula, oozing will be there. So you go first to the skin, then to the, I am not telling, you make the tunnel like your tunnel catheter. This is just one, this one only. First you go to skin, then go to the
vein. Okay. And while securing it, elastoplast, not elastoplast, that white plaster or micropore, any, that what you are using, that you make sure that it is not very small or very long also. Just half of the needle is covered, then another half is covered, so that it is properly secured. Some people will just here only to this thing, it is come outside, then patient is moving arm, that time needle is out.
Okay. And while taping the needle also, make sure that it is like the center only.
Yeah.
Sometimes you will tape it like this. What will happen? This tip will be touching the wall. I told venous pressure will go. Make sure that it is exact in the center of the vein. Maybe your cannulation is good. Sometimes you will do the mistake in taping the needle also. Okay.
And this is as you like become expert in the cannulation, then you feel like whether it is deeper or superficial vein or medium.
This is superficial, very superficial.
So here I went not
this is
very
little bit
superficial
stronger and prominent. Okay, this will not move. And these are the few hidden and slippery veins like this. Okay, that different patient will different type of veins.
Whenever you use the needle, this cannula lumen, okay, don't touch here. while taking the connection or maybe recapping it, don't touch this part like this or and all. Just take this like this or any other that blood tubing you are connecting. See, no need to touch only. Okay, so just connect it, then you rotate properly. Understood?
It might be the next story is
Sangala. So like that, another will be some centers maybe like one is that side means another is near the opposite side. That and otherwise, okay, that is depending on again patient's vein how it is. For example, here one more vein is there. Usually this vein, no, in patients it is little difficult to cannulate because this is slippery. Here it is stiff. But if you see patient's vein, that is a little slippery.
Vein.
Okay, so you have to, that time two people required. One person should hold the hand like this, locate the hand, vein properly, then you are holding, then you are cannulating. Usually this vein is little slippery. And one more thing while cannulating this part also, if it is counter punctured, okay, or tip is touching the wall, suddenly that area may become bulged. Okay, bulging means it is directly going near the chest also. It is very difficult that time. Then we have to remove the needle and we cannot do the dialysis sometimes that day. Okay, all those things you should be careful. That's why we told like, not like you are, it's okay, other people are coming, they are pricking, they are removing the blood, they give the injection. I can also do that. No. Okay, so never play with the fistula. So one more will be artery. So another batch I will show. So any doubts in this? First, no doubts.
Started? Okay. How many patients you did? Cannulation.
You can hear, no? Otherwise
Almost.
you can come this side.
How many patients? 10, 20, more than 20? More than 20. All of you? No. How many done cannulation? Just raise your hand. 1, 2, 3, 4. Okay. More than 10. Huh? Okay. So what are the challenges you face? Like, while pricking the needle, maybe. Unless you are not a heroine or hero, some this task maybe you face. What problems you face? Bleeding. While cannulating, oozing will be there. Okay. Then locating the vein, right? Okay. Then yeah, that what happened? Bulging happened. Okay. So what root cause you find out? Maybe mistakes happen. So what may be the reason that you find out? Okay. 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 Then what about bleeding? Same place. Area technique. Okay. Superficial one. Okay. So have you tried that with next time the skin, then going to the skin vein? What I am telling, while you prick, no?
Yeah.
Don't go directly into the vein. First you enter into the skin, then you have to go into the vein. Then that bleeding, slight oozing will be not there. But little bit pain will be there for the patient. That's why every time I am telling patient education and documentation. Education and documentation. If you educate, one will not educate. Another will educate. So he may think that one who is educating may be hiding our problem. Okay, everyone is educating, then he will understand, this is the problem, that's why they are going this way, like that. And you have to document every time. So what problem she has faced, next time when you are going, that maybe, last time they had side oozing. Maybe this time you have to come out of that. Like that the corrections will go. Okay, so you know that, then no need to teach much, you people know. So artery is always towards the anastomosis, 2 centimeters away from the anastomosis, and vein towards the heart side, opposite to the this one, anastomosis. So you see the vein here, it is very prominent, no? Am I right? Okay. So now I'll choose artery towards the anastomosis and vein towards the heart, this side. Have I chosen the side properly? Any wrong is there? Am I correct or wrong? I have chosen artery here towards the anastomosis, 2 centimeters away from the anastomosis, and I have taken this as a vein. I will direct towards the heart. So these are the 2 points, needle sites I chosen, whether I have chosen properly or not. No? Okay. What's the reason? Huh? Right. What's the mistake? Your answer is right. What is the mistake? Huh? Huh? Correct. Yeah, away from, I have chosen another segment. Away. And that is directing opposite direction. But still, my selection is not correct. Why? You see the arm.
Yes.
What happened? This is loop. This is loop. What will happen if I take artery and vein here? Recirculation. What I am taking, again I am recirculating. So I told in AV fistula we have the choice to avoid the axis recirculation. So you choose the vein away from the artery, opposite direction, to mainly to avoid the recirculation. But it will not happen with all patients. If good segments, good veins are there, first your choice will be like that, choosing the 2 sides. Okay, that is your first thing. Then how you are cleaning. Now you have chosen 2 sides. So what I am telling, now you have to follow the asepsis technique. Okay, suppose this point is your point of cannulation. Then you start from here, then go towards the periphery, like this. Once you move towards the side, don't come again to the center. Okay, and you have, suppose your sides are too near, like this. Then what you have to do, you start cleaning like this, you stop it here. Then you give the time to the choice to this one, then you clean like this, then you stop it. Okay, if this too away from this one, then you can go for the broader space. Okay, another thing, what you told, bleeding chances. It is prominent fistula and aneurysm, where usually the site oozing will be there. So first you go to skin, then you enter into the vein. That's why angle I told, like that you have to go. Directly if you go to the vein, patient will appreciate, no pain. He will be very happy, but oozing will be there. At the end he will scold you, see 1 bottle blood gone. And you will also feeling bad, and that is the chance for infection. So go to the skin, then you go to the vein. Not too much, like it is not like this one, tunneled catheter. First too much skin, then not like that. Just this one to go.
So one more thing, now like I'll just show you one needle how to cannulate. Okay. So how many of you already cannulated? 1, 2. Okay. So before cannulating, anything you are doing? What you are doing? How you approach patient? Sterilization, yes. How you approach patient? Because you people are interns, that's why I'm asking. Them I did not ask this question. Huh? Yes. First thing, they should know you people. Okay. Otherwise, they will be very scared. Okay. Because our dialysis patients are not like other patients. Because in any other field, what is the thing? Patient will come, take the treatment, go back. Or they'll come after 1 month, 1 year, like that. Or never come back. Right. But our patients are not like that. Once you did mistake, lifetime they will remember that. Okay, that person did like this, that, everything. Okay. So one thing, first thing, you just make sure that that patient knows you. Make them comfort. Tell them you are going to cannulate them today. You can ask them only, okay, which are the places, all those things. But decision should be yours. Okay. It is not like, that's why you are studying, right? Yeah. So decision should be yours, but you can ask them, okay, which is your arm, fistula arm, then check. Then ask any problem is there. Then needle sites, that puncturing site, where is the puncturing site? All those things you can ask. Okay. So I will discard this now. So all of you know the waste management system, all those things, right? Yeah. So just think that this is the sterile pack now. Okay. Pack means little bigger you will use, right? Yeah. So whenever, first thing you clean your hands, wash your hands properly, okay? And when you wash and come to the dialysis unit or you use the hand rub solution, make sure that after that you don't touch anything here and there, okay? Or any other person is coming and touching your hands, okay? So make sure that you are always holding your hand properly. Once you, or wiping the arm to your dress or uniform, okay? Those things also please don't do, okay? Yeah. Then one more thing, for example, in this now it is packed means, make sure that when you opening, then removing the needle and keeping in that. No. Okay. So in all the packs you will see that one, how to peel it. That area they will denote. So that area you should hold, peeling it in the tray itself it should fall. Not down or here and there. Okay. So sterile technique. So gloves also, before washing your hands, make sure that no bangles, no watch, no finger ring, nothing. Nails are cut properly. All of you know, right? In our field, we are not wearing jewels properly, no nail polish, no nail art. Yeah. So here, I kept this glove like this. So here one more thing, I am touching here, my hands are clean now, I am touching here, but I should not touch this inside part with bare hand, because this part is sterile, that you know, right? Yeah. So now I can touch this part, but I cannot touch this part. Why? This is sterile, now I am going to touch the patient's skin with that part. So just insert your, this one you practice, okay? Wearing the glove.
After wearing, you should not search your finger. Automatically
it should
go. Only. No, I am not. At first time you will not get that.
Yeah.
But doing the practice, it will come.
Maybe you felt automatically it is going while I am wearing it.
After wearing that, don't do like this.
Yeah. Okay. Usually you people do that. First thing you should see that what is the glove size. Okay. So see how I am holding this. I did not touch here, just this much only. Because this part is sterile, this part is sterile, this is unsterile. Okay. So when your fingers are going, that time only it should reach those slots only. Okay. So, okay, I am not touching this part, inside part, just this part I touch. Now I can make sure that this part also
and
properly.
Make that it is covering up to your, that's why that much length is given.
Wrist.
Few people, they will
till
leave it here only. No, complete you cover your hand. Maybe it will protect your, any cuts are there. While cannulating, you will also there in that much danger only. Not only patient, we are also in trouble only. Okay, so make sure you are also protected. Okay, once you wear that, make like this, and it will be, now you can do
make sure that all
hand
now you can.
If
make
you are
sure
not
that it is
comfortable with your hand, then next step cannulating will not concentrate. You will worry about your
problem is now this glove is proper to my hands. Okay. Now for example, if it is a 6-number glove or less, problem is it may be very tight. I am not able to just fold my fingers, or while cannulating I am not able to do it properly. Or maybe it is 8-number glove. It is falling down. While cannulating it is becoming loose. I am making it proper. That time maybe needle is pricking the patient. Okay. Those things you should make sure. And once you wear the glove, don't make
the mask
that mask proper. Most of the time students, no? Usually,
you feel itching in the nose. That will be there. That
everything.
is your sense. Sometimes it will be like we feeling like that. So all those things you have to overcome.
Or after that you are removing the pen from your pocket and giving to friend. Don't do. Okay. I think all of you are doing all these things, right? That's why some are smiling. Yeah. Once it is done, one more thing. Just we have to take the spirit and betadine, and if some centers may be having some other disinfecting agents, okay, skin disinfectant. So once you take, make sure that while just make sure that it is not touching the bottle, nozzle, or you are touching my hand, all these things. Okay. So I am keeping here betadine.
that is thick compared to your spirit solution. So you have to practice how to pour without spilling other side. Okay, not her hand and other. So that is also a skill, but practically you are understanding. Okay, so first you have to learn how to assist the procedure. Then you have to involve in the procedure. Then you have to teach the procedure. Then you have to become excellent in the procedure, right?
So first thing, during class, this topic presentation only ma'am said, first thing you should ask the patient to wash the arm and come. If they fight with you also, then also you tell them, first you clean your arm and come. Okay. Then one more thing, not only that area, first thing, you just ask the patient to lift the arm. Maybe this is the needle side. From here only you are cleaning the arm. Means back side of the arm also. Not only upper portion. Okay. So once that is, and that time you are not holding the patient's hand. Understood, no? Because you did not clean it properly. So once it is done, then now cannulation site. Okay. So for example, here I am cannulating now. So first thing on the point where I am going to puncture. Then now it is turning this and that side. Don't hold here. Patient will tightly hold. Okay. So it is now periphery. Understood?
You have to put little pressure, not too much pressure also. Not just
don't become scared that it is painful. No, it will not pain.
Unless your artery touches the this one.
This should not touch
the skin. Make sure that cotton only rubbing
because
the hand.
When you hold this, that is the problem. Some people, how they hold, like scissors, like this they hold. See here. So when you clean, you are not cleaning like that. You will clean, this forceps are touching the arm. No. So when you hold, make sure that this portion is like this. Just practice it. Open, close, open, close. Okay. Yeah. So again here, puncture site. And make sure that little, at least 1 inch surrounding is clean. Not only that, this one. Okay, at least 1 inch. Okay. And one more thing, you should know which all disinfecting agents are allergic to that particular patient, all those things. If no allergy, okay, you can go with these things. Okay. Then needle. So I am going to open it. I am not touching
you should be
here.
ready with the syringe. Immediately you have to connect.
Yeah.
Because this opening you should not
keep for a long time. So
Okay,
I am not touching the tip of that lumen. Okay. See here. Just connect.
Rinse the needle.
Now
remove the air.
I am removing the air.
And better you move the clamp towards the end, because if it is in the middle, then taping is also problem.
Understood?
In between, while you locate the vein, no, it will be
sometimes
that will be disturbing you. So keep it 3/4 in the down.
Clamp will be like this.
You move that time.
Problem
bring
is
it to here.
When after cannulating, when you are pulling it down, that time maybe needle also coming out. So make sure that while you are taking only, that time only.
And this is the right position to keep your clamp. Okay.
So,
and make sure whether clamp is well. See, when you open this one, you see the expire date, company name, everything. Then open. Then you see the any defect is there in the needle. Clamp it is properly, or this one cap is given properly or not. Wings are correct or not. These things you just check. Then you whatever equipment, if you do dialyzer, if you working with this with blood tubes, anything, any equipment you use, you see that catalog first. You read, open that, then you use.
Now, see here, this vein, it is like this,
and it is
bit
straight.
bent, then straight. So where to cannulate? Here, here, or here? Yeah. So first thing we have to see the fistula also. If for example fistula is somewhere here, usually actually wrist. Sometimes if it is failed, maybe sometimes little bit upper portion. So don't cannulate to the fistula only. Okay. So little away from the fistula. Okay. So one more thing, this veins also, usually in the like human vein it is little slippery, this vein. Okay. So you can first pull the arm like this and not arm, skin little bit This side, you can tell patient that you are going to cannulate. Understood? Yeah. So while taping it, what you have to do, and see, make sure that it is
going
going
freely
in the
or not.
freely, it is coming out freely. Okay. So arterial
And
node
ask the
needle,
patient any pain is there or
pain,
not.
or
Okay, any
sometimes
bulge
you
is there.
feel
You can see
something
here a
is
little bit
touching.
flow. You can feel.
Okay. So those things you should make sure. Then to secure it, 2 tapes, one half of the wing and needle, one this side. Okay. Some people like butterfly, all those things they'll put that. You just see whether it is actually required or not. Okay. So if it is actually required, okay, it's okay. You can do like that. Then make sure that if patient is moving the arm, fingers or one thumb is tied
The
to
cord.
the cord.
But before tying, you tell the patient,
Patient
for
take the
what
consent.
reason you are tying. Because handling the patient, you should not insult. Make him comfort for the dialysis. For what reason you are doing that. Without explaining, if you do, he will feel hurt. Okay, explaining with the concern only you are tying the
Now
hand.
that rules also there. Whenever you are tying, you should take the patient permission first. That's why. So make sure that you inform the patient, then you are tying the arm if required. Okay. And this after cannulation, once the dialysis started, make sure again you ask the patient any complications are there, any pain, any like flow problem that person is feeling, all those things, and check the venous pressure.
First
That
initial
you have
5
to
minutes
check.
you stand there, you watch venous pressure, any abnormalities there and ask the patient, then you leave the station. Okay?
So, if connection, you are taking connection little late, make sure that little bit heparinized saline is flushed and you keep actually without priming, without keeping machine ready, you cannot cannulate actually fistula. That you know, right? First you should make sure that machine is ready. Test passed, everything is ready, priming is ready, everything
And the person
done.
is ready to take the connection.
Connection.
Then only you connect.
Then only you should
do the
cannulate.
Keeping
Problem
the
is
patient half an hour early cannulate, patient also not feeling comfortable and that is not a good practice also.
And unluckily, if that machine is shut down,
That day you can't dialyze the patient. Simply you are pricking the
you are
patient.
pricking the patient and keeping that patient like that. Okay. So make sure that always everything is ready. After that, you are cannulating the patient. So while remove the gloves, how to remove? Right? I should not touch here. Why? It is. This is contaminated. I should not get the infection now.
Then you
By
should not touch
touching.
like this. You will be
Yeah.
contaminated. And
So-
don't pull it like this. Maybe
Understood?
any this one blood
Yeah,
is there that will
should
spill
not
on the another
splash
person.
on another person. So
just
like this. So inside I am touching now. I am not touching the outside.
And proper disposal.
Proper disposal. Okay. Then hand wash. That you know, right?
Any doubts you are having? I usually pseudoaneurysm they are telling with the AV graft. Aneurysm is weakening of the your vein. That is becoming weakened and it becoming the bulge. Pseudoaneurysm, that is why what I told, removing the needle, how should be? I told you have to cover the vein also. So sometimes when you just closing this one, maybe surrounding it will be bleeding and it will stop there. That is outside it is making. That is pseudoaneurysm.
Pseudoaneurysm.
That is not real aneurysm.
Aneurysm is vein only.
Usually that will help. That will happen with the your AV graft.
It's the
Whatever
layers are there.
precaution you take, that most it will happen with the AV graft. I think we need some this one measuring this one what medical this one intervention is required to check with the Doppler or something, X-ray something. But yeah, differentiate that one. Yes, usually physically real aneurysm that part will be very weak, like it is very thin. You feel that it will now
shiny.
burst. Pseudoaneurysm is a little bit hard it will be.
And one more thing, you never cannulate that pseudoaneurysm or aneurysm part. And usually that fistula bursting chances will be. And stenosis, all those things you know, right? While when arm elevation test, all those things are there. thrombosis while touching on
So
you.
venous pressure, high venous pressure.
Venous pressure
Usually
high.
for 100 blood flow, accepted venous pressure is 40. 100 is okay. Maybe cannulation, this one is there, narrow vein is there. But when it is 120, 140 for 100 blood flow, so something abnormality is there that you have to check.
And sometimes maybe collateral veins are there, many, and you felt it is the actual vein and you are cannulating. That time also bulging chance. So those things you should see. Main thing, sometimes new fistula, slippery veins means another person who is assisting that cannulation, who is doing the cannulation, to that person, that assistant, that is very important. How to hold,
How to locate the vein.
that is very important. Don't think that it is a very silly job. Person is holding
Supporting the
arm,
person to
supporting.
cannulate.
That is
That's why I told. In your beginning, you become expert in assisting the procedure. You should be a supportive. This one.
See,
Then
for
you
example,
jump into the
this-
field. You have to become expert in
This
doing the
vein
work.
is always
Then you
slippery.
teach. That is
Okay.
the stages.
So here patient will just keep like this arm. But while cannulating, person may change the arm, right? So one more person who is there, that person should make sure that this vein is not going that side or this side. So you are holding it properly, so that cannulation who is doing, that person will one more side, that person will hold and cannulate. Okay. We cannulate this vein also sometimes, no other veins.
Any doubt?
Thank you, Ms. Veena NK and Ms. Megha Nagaraj Nayak, for sharing your valuable insights. Your expertise truly enriched our workshop experience. Thank you, ma'am. I request our Dean, Professor Pratigna Suhasini Chia, to hand over the token of gratitude to our resource persons. As we wrap up this workshop, let's remember that the end of one event marks the beginning of many opportunities. Keep the conversations flowing, ideas brewing, and connections growing. Until we meet again, let's stay curious, stay connected, and keep pushing the boundaries of what's possible. Thank you all for your valuable contributions, and let's continue to make a difference together. Goodbye for now, but not farewell.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 जय